The capacity to learn is a gift. The ability to learn is a skill, but the willingness to learn is a choice. And as Steve Jobs has quoted, learn continually, because every time there is one more thing to learn. So a very good morning to all of you, and a warm welcome on behalf of Team Awesome Embicon 2023 on this Sunday morning. Before we begin our scientific sessions, there are a few instructions that I would like to give out. Periodically, in most of the sessions, there would be few multiple choice questions that would be flashed on the screen. The moderator for that particular session will read out the question and then the options and would say, your voting time starts now. It would only be then that the delegates will take the voting pads, which are provided on the seats, point them towards the screen. The ones sitting behind would have to be a little higher, and click on the most appropriate option that they feel is right. They would get 10 seconds to do this, at the end of which the answers would be displayed, the audience poll would be displayed on the screen. Thereafter, the expert for that particular session will discuss the right and the appropriate answers. So requesting everybody to please use the voting pads and give their options here. Any delegates who want to ask any questions or want to discuss, kindly use the mic which is provided, because the session is being recorded, so we need to be a little more audible. And I request the esteemed faculty for today to collect your appreciation certificates from the registration counter once your talk is over. The posters are displayed in the open area, which is just next to the dining area. And anytime in the break, delegates are requested to go and visit it, so that our participants are all encouraged. So, of course, without taking much time, I would now invite our young and dynamic treasurer, IIP Mumbai, Dr. Amruta Shirodkar, to come up on stage and start this awesome Embicon 2023. Looking for a great scientific session today. Thank you.
A very good morning to all the respected faculty, delegates, my teachers, seniors, and dear friends. I welcome you all to Awesome Embicon 2023. And now we shall be commencing with the scientific session. Before we commence, I just want to say that whoever wants to ask a question, kindly speak into the mic as this session is recorded. So we will start now with our first session for the day. The session is titled, What Pediatricians See, Penetrating Insights. The expert for the session is Dr. Hiren Panwala. Sir is a consultant pediatric radiologist at SRCC Hospital. And the moderator for the session is Dr. Sushma Save. Madam is Professor of Pediatrics at Nair Hospital. So I welcome Sir and Madam on the stage, please.
So, next 30 minutes, we will take you through a journey of imaging modality. And to do this, I have Dr. Hiren as an expert with me. The X-ray chest, which is the favorite investigation of ours, but we need to know what are the clues of interpretation of the X-ray chest, okay? So in addition of a patient's information and correctly labeled X-ray, right side and a left side, what is right? And as we have for patient management, A, B, C, D, E, similarly, we have for X-ray, A, B, C, D, E, F, G, H. So what is it? So I request Dr. Hiren to highlight on this. Yeah. Over to you, Dr. Hiren.
So yeah, without wasting much time, I would just briefly explain you the concept about the density. So whenever the tissue has got least density, the maximum X-ray will be passing on, and that will be seen as a black thing on the X-ray, just so we keep it simple. And those soft tissues which are having much more density, like metal or metallic foreign body, X-ray contrast, from there, the X-rays are not passed. The X-rays are absorbed, so they will be seen as a white thing. So that's the basic concept, right? So the air will be seen as a black, and bones will be seen as a white. And in between, you have got this kind of gradation of the density as a gray color. So other thing that children are not little adults. In children also, there are certain age groups, infants, newborns, and preterm. And those have different scenarios and pathologies that you have to take into consideration. So she was asking about what is ripe. So before reading any X-ray, you have to first make sure that the technique is proper for the chest X-ray, because without that, you cannot interpret the data. You can easily misguide your clinician, and you can easily make a fumble. So the RIPE is a mnemonic, and that stands for rotation, inspiration, position, and exposure. So this all thing I'll be showing you in the next subsequent slides. So this is an example of how exposure can fool you. So here is the overexposed film, in which we are seeing much more apparent increased bronchovascular markings, which is not the case. So when you see this kind of X-ray, then you will see that the child is having some sort of infection, viral bronchitis, and those kind of scenario. So that's, you have to have proper KV and MA. And in the present scenario, we have got digital radiography. So that's the helpful thing. We can adjust the contrast and we can make it appropriate. So what you should be able to understand that whenever the normal penetration is done, you should be able to see only the first 4 vertebra. The retrocardiac vertebra may not be seen. That is one of the thing. Other thing that you are seeing the vessels, it should be seen only in the 2/3 part of the X-ray. In the periphery of 1/3, you might not be able to see the vessels. That is a normal thing, okay? So if you are seeing this kind of excessive vessels reaching up to periphery, that is not normal. That means that the X-ray is overexposed and you have to adjust your contrast and KV, right? That was about the KVMA. Sometimes when you take the X-ray without that hair braid on the field, that can give rise to this kind of artifacts. So that was the hair braid artifacts. And we asked the patient to uplift the hair braid and then again repeated the X-ray. Otherwise, you will take it as a consolidation pneumonia or those kind of things. So these are some pitfalls that you should be aware about. The other thing that when you are reading the X-ray, you should interpret whether the inspiration is proper or not. So how we can make that thing? So you have to count the anterior ribs. So if generally the 6th rib should touch the central dome of the diaphragm. So this is the anterior end of the 1st rib, 2nd rib, 3rd rib, 4th and 5th. So ideally, the 6th rib should touch the central dome of the diaphragm. That is the normal inspiratory film. So this is the same patient. When you take the film in the expiration, you will see this kind of apparent diffuse haziness of the bilateral lung fields. So that also, then you will think that this patient is having ARDS or severe viral pneumonia or those kind of thing. So just to prevent those kind of fumbles, we should check that whether the inspiration is proper or not. So that is one of the factors that you should be able to see that. Other thing, that rotation, you have to see that from the midline of the vertebra. If the spinous process is seen, then you should see the distance from the middle end of the clavicle on either side. They should be at equivalent distance to tell it as the rotation is proper or not. And the centering should be ideally done at T4 vertebra. So these are some guidelines that you should follow. This is some literature. I'm not going to detail because it will take some time. But these are the KV and MA that we should give to the child when we are taking X-ray, especially in pediatric population, and that also differs between different age groups, right? So that is the thing, how to read chest X-ray. These are the A, B, C, D, E, F, G, H. That is the airway, bones, C for cardiac, D for diaphragm, E for effusions or extrathoracic soft tissues, F for filled and fissures, G for great vessels or gastric bubble, and H for hyla and mediastinum. So here is the frontal radiograph. So whenever you start reading a frontal radiograph, you should always start from the central to periphery or periphery to central. Either of these things will be equal, but you should have to start one proper protocol. So we start generally with the airway, central thing, that is the trachea and its bifurcation. Then we come to the mediastinum and cardiac. So this is the right cardiac border, which is formed by the right side SVC. And then as we go lower down, this will be the azygous vein impression here. And this is the right cardiac border, which will be formed by the right atrium, followed by, this is the aortic knuckle, which will be like aortic arch when it turns down. That is the aortic knuckle impression on the left side. That is the pulmonary bay impression. And this is the left cardiac border that is formed by the left ventricle. So these are the anatomical details that you should be aware about. And these are the descending pulmonary vessels which are seen in the lung fields. And that is the dome of diaphragm. Diaphragm has general concavity that you should be aware about. You should not miss the bones and the visualized upper abdomen, because sometimes upper abdomen will show some sort of gas in the under diaphragm or gas in the portal vein in a case of necrotizing enterocolitis. So those kind of things you should not miss. These are the clavicles that I was mentioning that you should not miss any finding. So that's the lateral radiograph, because generally we don't see often that normal anatomy of the lateral radiograph. So in the lateral radiograph, this soft tissue shadow is by the cardiac structures. Then this is the sternum and these are the spine. Just a simple rule, when we go from the cranial to caudal, the density of the lung should decrease. It should become more black. So if it is more becoming white here, that means that there is some pathology in this area, and that you have to correlate with the frontal radiograph, right? And this is the hilum, that is the trachea, and behind the trachea, this is the esophagus, right? So this is the lateral radiograph, how you can interpret.
Yeah.
So,
Thank you so much,
yeah.
Hiren. So as a clinician, we should go on a clinical scenarios. So the first clinical scenario for all of you is that clinical and radiologically confirmed pneumonia not getting better with right antibiotic, right dosages. What is next? Would you like to do an X-ray chest, UAG chest, X-ray and UAG chest both, or you want to go on a CT scan chest? Your time starts now for polling. Can we have the votes? Okay.
Okay, very good.
So almost 39.6% of our audience would like to go for the USG chest, and we'll see why you want to go ahead with the USG chest. So we'll go with the expert's opinion now. Can
Okay.
we switch on the PPT mode, please?
Yeah. So those who mentioned ULC chest, what was the idea?
Yeah.
Anybody can shout out? Yes, excellent. So there are some, I'm sorry.
Yeah. So what information does, you have already asked that.
Yeah.
So we go on this. Yeah.
Okay, so basically, in the previous radiograph, what we saw that there were certain clues that I'm just showing them that there was this kind of tracheal shift towards the right side. Even the mediastinum was shifting towards the right side. So that means there is some sort of significant mass effect on this area. Simple pneumonia usually doesn't cause this mediastinal shift. So there has to be some sort of massive pleural effusion or a pleural empyema collection, those kind of things which can displace the mediastinal structures towards the opposite side. So a simple way to prevent radiation, we can first start with the USG, because USG will show you that how is the fluid. The fluid is simple as anechoic, or it has got thick walled, it has got internal septations, loculations, debris. Debris are fine debris or they are thick debris, they are not moving. Those kind of information USG can give you, which sometimes CT also cannot give you. CT also sometimes misses the loculations. So that's one of the important finding I wanted to mention, that when you want to assess how bad is the pleural empyema, the ultrasound is more better and MRI is more better than CT, because CT sometimes will not show you loculation, it will be only seen as some hypodense thing. So you might not see the severity. So here, these are the findings that we saw in this case, that patient has multiple this kind of loculations, peripheral thick walled. So it was a proper pleural empyema case. And these are the required thing for a pediatric surgeon to go for decortication or to put a ICD tube. In this kind of bad scenario, it's better to go for the decortication, right?
So is there a role of a lateral X-ray in today's era of CT? Which one in what situation?
Yeah. So nowadays, like in our practice, what we have observed when I was working at CMC Vellore and right now in SRCC, currently the lateral radiograph are not adding much values in most of the conditions. There are only few conditions where we are practicing lateral radiograph. One thing is that is there a persistent pneumothorax and you want to assess, despite of putting ICD tube, the pneumothorax is not getting drained or it is not resolving. Then you want to assess the tip, where is the tip of that ICD tube. In those kind of scenario, you can take the lateral radiograph. And other thing that being cardiac focused hospital, we often do cardiac surgery, and after surgery, they want to see the retrosternal collection. For that aspect, our cardiac surgeons routinely do that post-cardiac surgery lateral radiograph just to see retrosternal, is there any soft tissue density which can be a collection. So these are the scenario. But to localize the pneumonia where exactly it is there, right now, there is no need of doing that. And even if you are suspecting mediastinal mass, the next mode will be either CT or MRI. If it is posterior mediastinal mass, we'll go with the MRI to look at the spinal canal invasion. If it is rest of the thing, then we can go with the CT chest.
So exactly, when do you ask for a HRCT?
So just to give you a simple difference between routine CT and HRCT. So in routine CT, it's a volumetric image, and the scan starts from top to bottom without leaving any gap. So entire part of the lung, each pixel and each part is covered in the scan, so that if any nodule is coming, that nodule will be represented on the final data. On the contrary, HRCT, in the conventional time, what we had seen that there was a gap of either 10 millimeter or 7 millimeter gap between the slices. So if the nodule is very small or the finding is very small, there are chances that if it is coming in between the slide, then you can miss that finding. But in the current modern CT scan, we can generate those HRCT kind of scans from the routine chest CT volumetric data also. So that's the advancement of technology that we can use it, and we don't have to specifically go for that HRCT chest technique with gap. So just to show you that the image resolution difference between the routine lung and HRCT. You can see that on HRCT, the bronchovascular markings are much more sharper. The lung parenchyma definitions are more clearer as compared to the hazy findings on the routine chest. So we should use this HRCT in certain scenario. So these are certain indications of the HRCT, and the important ones are whenever there is suspicion of interstitial lung disease, whenever there is diffuse lung disease, which is commonly seen in infancy and children, and in a case of fibrosis, those kind of scenario, you can do HRCT. Then another frequent question that is asked that when to do contrast with CT chest. That is also commonly asked. So when you are suspecting any vascular rings, mediastinal or lung masses, when you are suspecting pulmonary sequestration, you have to do contrast. If you are evaluating congenital heart disease, that also you have to do contrast. And certain scenario like you want to assess the necrotizing pneumonia and you want to assess the parenchymal necrosis, or you want to assess pleural empyema, those kind of scenario, you have to go IV contrast, right? So these are the indications of the contrast in CT chest.
Yeah. So we move on to a clinical scenario 2. Here you have a 5-year-old female with pain in abdomen on and off. She continued to have a pain in abdomen treated symptomatically with history of a urinary tract infection at the age of 3 years. And right now she's followed up with the present USG report, which reveals medical renal disease with mesenteric lymphadenopathy of 1 to 1.5 centimeter in size. So what will be your approach to this child? Would like to do on a repeat USG, CT scan abdomen, do both repeat USG and CT scan abdomen, or you'll go for a barium studies. Your polling will start now. Your time starts now.
Okay.
So majority of the people wants to go ahead with the CT scan abdomen. So can we know the reason? Any one of you? Because we have a time constraint. So be fast, otherwise we move to our expert's opinion. Yeah. So what all should a well-done USG KUB report cover normally? What should pediatrician focus on in the report?
Okay. So just wanted to mention that we should not directly go ahead with the CT scan. If it is not done by you, and because the USC done by expert sonologist, that makes a lot of difference. Whatever you want to convey, that you wanted to assess the lymph node morphology, that also can be well taken care by the USC only. Why you want to unnecessarily radiate a child just to see that how is the lymph node and how are the kidney. Kidney are also well seen on USG. In fact, better than in the pediatric age group. If you use that high frequency probe, I wanted to give one message that when you are assessing kidneys in pediatric probe, you have to use that 5 to 12 megahertz frequency probe, so that you can actually see the cortex and medulla, you can actually see the small cyst. So that is the take home message from that. You should always use that high frequency probe in pediatric population. So whenever USG KOB report is given, you have to first mention size is very important to determine which side is abnormal. Then you have to mention about parenchymal thickness, the corticomedullary differentiation. Then if it is hydronephrosis, how severe it is, and that the most important parameter is renal pelvis AP diameter. That is also pre and post void you can take, and you can see is there any difference is there or not. The ureters are dilated or not, that also you have to mention. Bladder wall thickness, that is also important. You have to assess bladder wall thickness in the distended bladder. If it is more than 3 millimeter in well distended bladder, that is abnormal. And in a collapsed state, if it is more than 5 millimeter, that is abnormal. Then in a case of cystic renal disease, you have to see that the cysts are only one side or both side. They are single or multiple, and they are macrocyst or tiny cyst, and location, whether it's cortex or medulla. So these are the things you can mention in your report that makes a lot of difference, and that can lead to a appropriate diagnosis. Yeah.
So can USG miscalculate?
Answer? Yes, okay. So yeah, of course, so in a pediatric population as well as adult, the sonography is the initial modality of choice to detect any calculi. But those calculi who are less than 5 millimeter, and they can be missed because they don't show that posterior acoustic shadowing. So generally the calculi, they will show a cast shadow on USG sonogram. That's how we pick up the renal stones. But small stone, they may not show that shadowing, so that can be missed because that can merge with the renal sinus fat. The normal sinus fat also will be hyperechoic, so that will merge with that data, and we might miss that small calculi. So these are the reasons that USG can miss the calculi. And it's not about the structure. In CT scan, the composition of the stone matters because sometimes radiolucent stone can be missed on the CT scan. But USG, that is not the story. USG, how big is the size and whether it's causing shadowing. These are the important thing to detect, right? So that was the answer about that thing.
Yeah. Can USG pick up a VUR?
Well, routine USG, that is not sensitive or specific for picking up the VUR, and we should not encourage also that there are clinicians asking like radiologists that can you see VUR on the routine sonograph. That's not happening. So you have to do with the MCU, that is the voiding cystourethrogram. And sometimes it has happened that on USG the kidneys are normal, but when you do MCU, you will see that grade 3 or grade 4 kind of reflux. So they both are not correlating well. So whenever you are suspecting reflux, you have to do MCU to complete evaluation. But there are certain clues on USG that can potentially say that this child might be having reflux. One of them is that if you see the complete duplication on one side in one kidney, duplex kidney, if you see that the ureters are dilated and they have some sort of peristalsis, and if you see calyceal dilatation. So these are the three things that can probably say that the child might have reflux. Recently, in certain centers and abroad, they are using this contrast-enhanced voiding cystourethrogram. So the contrast is injected into the bladder, and they are the microbubbles basically that we see on USG, and if that microbubbles are going into the ureter on screening, that can pick up the reflux. And that has shown that it has got same result and for the detection of VUR as parallel to the VCUG, that is the MCU, right?
Yeah. So your take on renal scan, DMS and DTPA?
Renal scans. So we just understand that DTPA is look to like how the kidney are functioning. That it will give you the idea about left and right kidney functions separately, and sometimes it can give an idea that where is the blockage, and that can be detected on DTPA. And DMSA is for the structural. Is there any scar or something? So that area of that anatomy can be seen, or if the kidney is in normal location or it's abnormal location. So if the kidney is in pelvis, then DMSA will show tracer uptake and abnormality in the pelvis area. So in that way, you can identify the ectopia also. And of course, it is mainly useful for the renal scarring secondary to infection or recurrent insult.
Yeah. So we keep on getting all these findings on the USGs, like minimal free fluid in pouch of Douglas, minimal ileocecal thickening, thickened bladder wall, probe tenderness. So what is the significance of all these findings, Dr. Hiren?
Well, here, these are the all things that we call back the clinician that what you are finding. So because these are the things which clinical, the correlation matters a lot, because isolated this kind of finding doesn't carry any value. We have seen this minimal free fluid in pouch of Douglas in a female patient who has started menstruation. That is normal physiological for that patient. So that should not be taken as abnormal things. Similarly, minimal ileocecal thickening, when the ileocecal junction is collapsed, it will show minimal thickening. That doesn't carry anything. But if you say that the patient is having suspicion of appendicitis and those kind of things matters, that can be a positive finding for that region. Or the patient might be having recent enteritis or enterocolitis kind of thing. So it's all based on clinical history and the lab values. Again, thickened bladder wall history make a lot of difference. The child is having neurogenic issues or not. The child had recent infection or not. Those kind of things will guide us to point out appropriate report. And probe tenderness can be seen in a patient when they have acute appendicitis, and sometimes the patient having testicular or ovarian torsion, they also have severe probe tenderness. So these are the findings that will ensure us, or that will add some specificity when we are reporting our diagnosis, right?
Yeah. So is CT justified to diagnose appendicitis?
Yeah. So again, the ACR, they recommends that initially you start with the ultrasound only. And ultrasound, 70-80% of the cases, they will detect appendicitis. So when you are screening first, you are not finding, but still the suspicion is there. Then there are several methods are there, like graded compression method on USG. And you can slightly change the patient position with anterior oblique location. Then you try to find out that appendix is visualized or not. still you are not visualizing. And there are certain journals which say that you can rescreen the child after 3 or 4 hours because the gas would have moved from that area. And after that also, you are not sure and the strong suspicion is there, then CT is justified in that. And you should do only dose optimized technique for CT scan, only single phase. Oral may not be given, that's not needed, but IV contrast can be given, and only single phase, venous phase we should take. That will cover, solve your doubt of appendicitis. So that's the thing I wanted to convey, that CT can be used when your ultrasound is not solving and your doubt is very strong. And recently, there are certain institutes like AIMS and CMC Velo, they have started doing MRI for finding out appendicitis also. But the thing is that it may not be practically possible if the child come acutely and is not in fasting and all. So those kind of scenario we have to deal with, and we have to ultimately go for CT scan.
We have 8 minutes left.
Yes.
Yeah.
So are barium studies done nowadays for any indication, barium swallow meal or barium enema?
Yeah. In a pediatric population, the bariums, they are done frequently. The barium swallow or meal, these are the indication I am not jotting down, but again, assessment of the esophageal motility, reflux disease, these are the very common situation where we use those kind of dynamic studies where actually you can see that how the passage of contrast is going on. And enema also frequently done in a case of Hirschsprung disease in neonatal age group. You want to assess the meconium plug, ileus, microcolon, those kind of situations.
Yeah. So here we have a third clinical scenario, 2-year-old male child with significant head injury. So what investigation will you do? CT scan brain plain, MRI brain plain, CT scan brain with contrast, MRI brain with contrast. Your time starts now.
No. So, yeah,
Yeah.
I agree with them.
Yes. So can we switch on a PPT? Yeah. So head injury when CT and when MRI, I think our audience is well-learned
Well,
audience.
yeah.
So we go on next. Yeah, head injury.
Yeah, so in a
Over to you.
Yeah.
Yeah.
Acute setting, yeah, CT brain is the initial investigation because we are not wasting much time. Within few seconds, we can do the CT scan. MRI is done only when the CT is normal and clinically there are a lot of neurological deficit which is not explained by the CT scan. In those kind of scenarios, you can do MRI. And of course, MRI is more sensitive in picking up of small subarachnoid hemorrhage, the hemorrhagic contusions. But if they are changing the management, then only we should do MRI in an acute setting, right? So these are the things that MRI scores over the CT scan.
So when with contrast and without contrast?
Okay, so in a neuroimaging, these are the certain indications that we should use contrast whenever there is suspicion of infection, tumor, any vascular malformations, demyelination also we should use contrast. And there are certain metabolic disorders like adrenoleukodystrophy, Krabbe's, mitochondrial that gives some additional value when we use contrast. So it's not like that metabolic condition may not require contrast. There are certain scenarios in which you can use contrast and that can help you.
Yeah,
And,
role of a CT MR.
Yeah, so when we do CT or MR angiogram in head trauma, so when you see on CT scan the fracture is traversing through the carotid canal where there is a potential chance of injury to the ICA, when there is concern for the vasospasm, and if you see that intracranial hemorrhage which is atypical for trauma, when you see the hemorrhage in the basilar cistern, when you see large amount of subarachnoid hemorrhage in the Sylvian fissure, where you are suspecting that there might be underlying aneurysm which is giving rise to this kind of hemorrhage, those kind of scenario you can do CT or MR angiogram.
So when do you repeat a CT or MRI? Does it help in some situations?
Yeah, definitely. That definitely helps in follow-up of the cases. Those who are doing neuro practice, that they will be aware about that. If you want to assess any infection or tumor, if you want to see that whether the findings are resolved or how is the treatment response, those kind of scenarios, MRI or CT may be needed. And other thing would be that when your clinical findings are not matching with the initial finding. For example, in a case of fires or certain scenario, when the initial MRI will be normal, back normal, but still the child is not waking up, child is still unconscious, and you want to see that how much damage has occurred over time. In those kind of scenario, you can do repeat MRI imaging, which may show further additional finding on follow-ups. Then in a case of suspected aneurysm post-trauma, when the initial CT angio is negative, still the hemoglobin is dropping and still there is suspicion of that there might be aneurysm. In those kind of scenario, you can repeat CT or MRI angiogram. So these are certain scenarios that you can use repeat scans.
I think this will be a last scenario for the session today. 8-year-old female child with history of a first episode of a right side convulsion without loss of a consciousness with normal CNS examination. What are you going to do in imaging modality as? CT scan brain, MRI brain with MRS, MRI brain with MRI. Your time starts now.
Okay, MRI brain, yeah. So that's the correct answer only. In a case of epilepsy, the question will be whether we should do CT or MRI. The answer is we should always do MRI because pediatric setup, it's not easy to assess on the CT brain because the myelin is not mature. You will not be able to differentiate between the gray matter, white matter well. So always use MRI. It has got no radiation, and there are certain scenarios in which MRI will definitely help you that this is look like stroke and this is like stroke mimics. There are certain conditions which can clinically feel like stroke, but on MRI you can differentiate this is not stroke. And of course, for the myelin assessment in less than 2 years, MRI is the investigational choice. CT will not help you in assessment of that.
So what about MRS?
Yeah, so basically I would like to simply say that MR spectroscopy basically is it's a technique in which we are trying to see the chemical composition of the brain in certain areas where we are finding the pathologies. And these are the markers which we evaluate at different parts in different ppm. So this is the image that you acquire at the end of the MR spectroscopy. And we, by this technique, we try to pick up certain abnormal metabolites. For example, this was a case of Leak's disease, that is the mitochondrial disease. And we are assessing here inverted lactate peak at 1.3 ppm. So in this kind of certain scenarios, MR spectroscopy can be useful in certain metabolic cases. It can also help in certain tumors, like whether it's high-grade or low-grade tumors, that kind of scenario, MR spectroscopy can be useful. And in certain infection also, if you want to see large lipid lactate peak, like for example, TB will have that large lipid lactate peak, those kind of scenario, MR spectroscopy can be done as an ancillary tool, as an additional weightage to your report.
So take on CT angio versus MRI angio.
They both has got equal sensitivity and specificity. So it's a matter of whether you want to save radiation and how urgency is there. If there is no urgency, we can wait for some time. The child can be sedated and it can be done. Then MRI should be done because it has got no radiation and we can find out more findings that is not seen on CT scan. However, CT is faster, no doubt. So in emergency with acute trauma, if you're suspecting some vascular injury, you can go ahead with CT brain with CT angiogram, right? So that's the take on, both has got equal thing. That is case-based scenario.
Yeah, brief on epilepsy protocol, please.
Yeah, so when you are suspecting some sort of focal cortical dysplasia or focal lesions and you want to tell your radiologist that we need some epilepsy protocol. So that epilepsy protocol includes some special thin sections at the temporal lobe. That these are the oblique coronals at the temporal lobe, and it has got this kind of inversion recovery sequences which differentiate between gray and white matter better, so that we can find small findings, small focal cortical dysplasia very well. And we should use 3 Tesla, that is the investigational choice. Whenever you are sending for epilepsy protocol, try to find a hospital or a center where they have got 3 Tesla, because that will give you the maximum output.
So I'll just take 1 minute, sir, for a take-home messages. Indications-based appropriate selection of imaging modalities should be the trend in pediatric population. Knowing limitation and advantage of each imaging modality is very useful in clinical practice. Very important to know age-based organ size and normal variations. Judicious usage of USG helps in many of the pediatric diseases, saves radiation, and as helps in management of the clinical certain scenarios. The best interest of a patient lies in a judicious combination of a careful history, physical examination, and appropriate investigation. And at the last, we all know this, it is always important to correlate a report clinically. Thank you so much for patient hearing. Thank you, Dr. Hiren.
Yeah. Thank you, Thank you, organizer, for giving me the opportunity. Thank you. Yeah.
Thank you so much, Dr. Hiren and Dr. Sushma, for that excellent presentation. Before we move on to the next scientific session, I just have a small announcement. We received a request for Sankashti food today from 5 to 6 people. If anyone else has a similar request, I request them to kindly give it at the registration counter outside.
Also, there are these writing pads, some writing material which is provided here. So if anybody needs it, just let us know. It's put here on the platform.
Okay, so with this, we now start with our second scientific session for the day. Our second scientific session is titled Genetic Jenga, for which we have two experts, Dr. Shruti Bajaj. Shruti Bajaj is a clinical genetist. She is the director and consultant clinical genetist at the Purple Gene Clinic, Mumbai. She is also attached at SRCC Children's Hospital, Sir H.N. Reliance Hospital, Cloud9 and Saifi Hospital. We have second expert, Dr. Amisha. She is also a consultant clinical genetics in Mumbai at Wadia Children's Hospital, Nanavati Super Speciality, Surya Children's. And the moderator for the session is Dr. Rajesh Kasla. Sir is a consultant pediatrician at Neon Critical Care, Malad. I welcome the experts and the moderators on the stage, please.
Thank you, Dr. Amrita, for the introduction. Good morning, everybody. And before wasting further time, I dwell into the second topic of awesome Embicon, that is genetic Jenga. Jenga literally means a competitive puzzle game. And in today's era, we have got so many diagnostic tests available in genetics that we as pediatricians are divided into two groups. One group where there is a sense of disbelief or futility in doing those tests, and there is another group who would like to ask for whole exome sequencing test as if doing a whole body CT scan, isme kuch to milega. So we have our experts who are going to tell us about this diagnostic test. And without wasting our further time, before playing this game, let us understand the format of the game from our expert, Dr. Shruti Bajaj.
Thank you, sir. So we'll first try and get some concepts correct about what are these genes, what are exons, what are introns. We are aware that the DNA resides within the nucleus of the cell. Now imagine if I was to take the cell, take the nucleus, remove out this genetic material, which is chromosome, a highly packaged genetic material, and I unwind it. Keep on unwinding it until, as you see on the screen, it unwinds to the final functional unit, the gene. So in human beings, diseases can be at different level. It could be a large error at the level of the chromosome, say Down syndrome, Turner syndrome, where an entire chromosome gets duplicated or triplicated. It could be a relatively smaller error at the level of the chromosome, what we call as microdeletions or microduplications, like DiGeorge syndrome, Williams syndrome, and it could be errors at the level of the gene, like thalassemia, cystic fibrosis. So understandably, for different errors, we need different lenses. We need different tests, which we'll try and understand in the next 20-30 minutes. Now, I'm just focusing on the gene. You know, when we know that from the DNA, the mRNA gets formed within the nucleus. This mRNA comes out, attaches to the tRNA, and the protein is formed. We need to understand before this mRNA is formed, it is actually a mixture of what we call as introns and exons. The introns are removed out, and the exons are then brought together. So the exons can be taken as the main actors on the stage, very important. They are going to play a very important role in coding the final protein. And so it's easy to correlate why 85% of known human diseases have their mutation within these exons. And so you would understand why we want to look at all the exons put together. Although these exons account for just 1% of our entire genome. Next slide, please. And this is what I was trying to tell in the first slide. You have errors at different levels. It doesn't mean that a smaller error will cause a smaller disease or a milder disease. For a relatively large error, 5 megabases or more, you can have karyotype and fish. For a relatively smaller error at the level of the chromosome, you have something called as MLPA and microarray. We'll understand these terms very soon. And then, of course, at the level of the gene, single base pair errors, you have next generation sequencing, what we are very fond of, clinical exomes, whole exomes. This is the level that it looks at. Next slide, please. So if you take a corollary, if I have a library filled with books, and I just want to find out is my Nelson textbook there or not there, I can eyeball the library. I don't need a fine lens. And this is something like the karyotype, which is just giving me a bird's eye view of the entire genome. Next slide, please. But if I want to find out if my favorite chapter on metabolism is torn from Nelson textbook or it's duplicated, then I need a finer lens. I'll need to open the book. So for smaller errors, you need the microarray. If I want to check whether there's a spell error within a given chapter, just looking at a torn page or a duplicated page won't help. Then I need the gene sequencing, I need the NGS. So this is just to give a very broad idea about what all of these tests do.
Yeah, so after understanding this format of the game, let's start the game. This is our first case where this baby is born of non-consanguineous marriage. Baby was born full term and the antenatal scans were normal. There were no serum markers that were done. And at birth, the neonatologist noticed that the child is having dysmorphism. We all know this is straightforward case of Down syndrome. My question is, what test would you opt for confirming this clinical diagnosis? Should we ask for FISH? We ask for whole exome sequencing, microarray, or karyotype? Your time starts now. Well, I'm very happy that 11% have answered FISH as the test of choice. Can I have somebody in the audience who have said FISH? Please. Your comment.
So I actually wrote FISH because I thought that since clinically I know that this is Down syndrome, that it would probably be a investigation of choice. However, karyotype would help me to find finer details.
Yeah. So let us know from the expert, how does FISH have an edge over karyotype, or karyotype is the investigation of choice? Please. Dr. Ami?
So actually both A and D wouldn't be completely wrong, but karyotype would be the test of choice or the ideal test. If we can go to the slide more, PowerPoint. So what we know is, just taking Downs as an example, you do have trisomy 21, but there are various ways in which this trisomy can occur. And how it is important to understand, why it is important to understand is because the type of Down syndrome, the way it occurs, will determine the recurrence risk in the next pregnancy, and that will also determine how you're going to be handling the future planning in the pregnancy for the family. So that's why karyotype is important, because that's a test which gives you the structure. So if you can go to the next slide, this is how a FISH looks. So if you can see here, you can only see the probes. You cannot see how, the trisomy is occurring, whether it's 3 chromosome 21s, whether there is a translocation. That is not obvious over here. So yes, FISH would be a choice when you're in a hurry, when you're doing a prenatal test. But ideally, you need karyotype at the end of it to go back and help the family with recurrence risk. And both karyotype and FISH can be used whenever we are suspecting aneuploidies. The important thing is, FISH is useful when you know what you're looking for. So here we knew that we were thinking of Down syndrome, and that's why we could offer FISH. But say it's it's not a very obvious dysmorphism, and you want to sort of rule out mosaic Downs, we all know that they are not very classical, then yes, karyotype would be the test of choice. So if you can just go to the next slide. So, just to put it in short, for example, karyotype is more like a machine gun. When you fire, you're going to get all the chromosomes which are visible. But FISH is very specific. So when you know that you want to hit the bull's eye, FISH is useful. But structure is something which is not visible with the FISH, and that's why you will definitely opt for karyotype, ultimately, even if it is a FISH-positive Down syndrome for future pregnancy planning. Also, one important thing, karyotype takes a little time for the results to come, so it will take about 7 to 10 working days. FISH can be much faster. Nowadays, you can get report within 48 to 72 hours as well.
As a clinician, will I be wrong if I ask for chromosomal microarray or whole exome sequencing here?
So it's basically, you're going beyond the machine gun also. You're looking, something like, throwing a bomb, because you're looking for something at the chromosomal level. So you'll be wasting the patient's money. It's not like you will not pick up downs, but it's not the ideal test of choice.
Thank you. So with that, we move to the case number 2. Now, these are cases of 2 kids. One who was born in the age 2003. You can see the karyotype. I don't want to describe in the detail. This was a case of Edwards syndrome. The first child was born in 2003, and the second pregnancy was in 2005. In the first pregnancy, the karyotype was done, which was normal. And during the second pregnancy, amniocentesis was performed, karyotype was performed, which was normal. But the child again came delivered with the same phenotype of Edwards syndrome. So we have got 2 children with phenotype of Edwards syndrome, and karyotype was normal. Even the parents' karyotype was normal. So in this case, do you still feel that there is some genetic cause or something else? Can I have a raise of hands whether this is genetic or non-genetic? Genetic? Because we are sitting in a genetic session. Okay, if it is genetic, then I would like to know, please start your voting, whether what test needs to be done. Should we repeat a karyotype, or we should do FISH? We should ask for a chromosomal microarray or whole exome sequencing. Your time starts now. Well, maximum is answered for whole exome sequencing. Nobody has answered to repeat a karyotype because this was done in 2003 and 2005. Okay. Can I have the expert opinion?
So can we have the slide, sir? So see the previous slide. One thing I think we all agree that this is genetic and it has probably got missed by the previous lens. It's like telling in 2003 I was looking at the moon from the earth, and 2021 I have a Chandrayaan that can go and take the images of the moon from the satellite. So resolution matters. We definitely need to look at the genetic material at higher resolution. So repeating karyotype and FISH is not going to help us. Between microarray and whole exome, actually the test of choice for multiple congenital anomalies where the etiology is not clear, for intellectual disability where the etiology is not clear, the test of choice from 2005 onwards was the microarray. It got introduced in 2005, 2006. So technically, chromosomal microarray is the test of choice over here. So next slide. And in this case, you can see, as I told you, this is a microdeletion, microduplication causing a severe disease. This child had 2 errors, and this is so fine that it got missed by the karyotype, correct? Are we wrong if we would have done the whole exome? I think in the next case where Dr. Ami will show how nowadays whole exome is taking over some indications of microarray, we will understand. I would just say that even if you do a whole exome, you may or may not pick up all of these errors. So the answer of choice is still, in today's date, a chromosomal microarray. I would not say that whole exome is the right answer. You may or may not pick it up with a whole exome. And it replaces karyotype as a test of first choice since 2005.
Okay. With that, we move to the third case. This is a 4.5-year-old female child, and this is the phenotype, which I would not describe in the detail. We all know this is either we are dealing with a suspected case of Ehlers-Danlos syndrome or Marfan syndrome. And here the question again is that when we have a clinical diagnosis of Ehlers-Danlos or Marfan, should we do a genetic test to confirm or leave it alone? Yes or no? Raise of hands, please. Yes. So if yes, then what test? Should we do a targeted panel just for connective tissue disorders? Should we do a chromosomal microarray? We do a clinical exome sequencing or whole exome sequencing? Your time starts now. Well, I would have also gone with 26%, the first one. Anybody who has answered this targeted panel sequencing? One representative, yes, ma'am. Can I know the reason why you asked for the targeted panel?
So hello. So we need to differentiate Ehlers-Danlos. We need to differentiate between Ehlers-Danlos and Marfan's. Both are of connective tissue type. That is why we targeted tissue sequence.
Okay, ma'am's answer was that we need to differentiate between Ehlers-Danlos and Marfan's. Now I would like to have the expert's opinion, Dr. Ami.
So the fact that I would choose a targeted panel would be because I was thinking of a connective tissue disease. And so I have some diagnosis, but not the complete diagnosis. And that's why I opted for a targeted panel. But what we need to realize is, okay. So what we need to realize is both these conditions, as we know, are single gene disorders. So now we've gone to the much finer level of the DNA. And when we go to such conditions, what we are looking at as gene sequencing. So we are looking at the level of the gene. Now in this, you have two types of tests which are available, something called as Sanger sequencing, and the other is next generation sequencing. So Sanger sequencing is just picking out one thing. You're just focusing on one gene and in fact just one defect in that one gene. So it's like just picking out one fish for dinner. Whereas NGS, when you're looking, it's basically collecting all the genes together and looking at them. And if we can go on to the next slide, like Dr. Shruti explained, that our genes are also further divided into introns and exons. So exons are the ones which are actually visible in the forefront, and introns are the ones which are backstage workers which are there. Now most of our diseases are associated with exons. So when we are looking at sequencing, we have different options that we can choose from. So panel is like when you go to Zomato and choose for a vegetarian dessert. That's how panel is. You know what you're looking for, but not exactly. You want something which is vegetarian and dessert, and you look for the options which are there. When you're looking at clinical exome, when you say you want to have only vegetarian dishes, that is clinical exome. You're not going to get anything which is non-vegetarian. So it's basically like a bigger panel, and in this case, generally it covers the OMIM represented genes which are there. Now when you're looking at whole exome, it's like, you're looking at all the different restaurants which are there in Zomato, and that is where, you will get everything which is there, all the genes which are covered. It's not going to be focused on one single particular condition or gene. And when you're looking at whole genome, it's like a Google search. You're looking at the entire DNA, introns and exons. Now, for a clinical person, I think focused panels to whole exome is what we are looking at right now. We don't really opt for whole genome very frequently. And in this case, that's why all the three options, whole exome, clinical exome, or targeted, would be correct. Only thing to remember is that oftentimes when we choose panels, there are genes which are newly diagnosed or newly detected, which are missed in the panels and may not be included in the panel. So if it's a new restaurant and a new dessert, it may not be listed on Zomato, and hence you may not really get it. Clinical exome will have, again, similarly, all the genes, but not restricted to a particular condition. And that's why, say, if you're thinking of connective tissue disorder, but say if it's actually something else, if it's some other molecular abnormality, that will obviously be missed when you're doing a panel or a clinical exome. And when you're looking at an undiagnosed disease or something which is very rare and new, that will be missed with a clinical exome. So these are the three stratas that you can opt for. So in this, actually, even though we were suspecting a connective tissue disorder, we opted for a clinical exome sequencing. And now when you look at the cost of the panel and clinical exome is near about the same. So we opt for clinical exome when we sort of have the diagnosis. And here we can see that we did detect Ehlers-Danlos type 6. And we found out, we did the Sanger sequencing in both the parents for the gene which was, gene abnormality which was there. And we found that one of them was coming from the mother and one of them was coming from the father.
Yeah, my question is, how does the clinician ensure that the genes of interest are covered in particular test?
the best thing to do is the lab which you are referring to, you can ask them for the list of genes which are covered in the panel. In fact, they will also give you the list of genes which are covered in the clinical exome whenever you are doing it. So when in doubt, if it comes back as a negative report, say here it had come back as a negative report, I would ask them for the genes which are covered, and I can look for the gene of my interest based on the clinical phenotype.
All right. So the idea is that we should all start learning how to use the Zomato app and ask the proper vegetarian dessert. So we go to, yeah.
Okay, so sorry, I just missed out on this thing. Like Dr. Shruti was mentioning, since 2005, we've been using microarray as a test of choice for multiple congenital anomalies and developmental disabilities. But there has been a recent paper in 2021. And because of the change in the pattern and change in the technology that we have, whole exome sequencing is soon replacing the microarray. And one of the reasons is whole exome sequencing in the current scenario is able to pick up about 70 to 80% of copy number changes as well. So that's why in the case which Dr. Shruti spoke about just before my case scenario, it wouldn't be wrong to do a whole exome sequencing. We could have fit out. But like she mentioned, smaller deletions and duplications are still missed. So you would still need a microarray even with a negative whole exome report.
Yeah, we shift to the next case, a short and fast case. This is a 10 days old baby who was admitted with respiratory distress, childhood hypotonia, absent reflex, but alert look, very much suggestive of spinomuscular atrophy. So here, what would be the question that is going to come for the audience? What would be the genetic test of choice? Sanger sequencing for SMA, karyotype, whole exome sequencing, none of the above. Your time starts now.
You have 10 minutes left.
Okay, maximum has answered Sanger sequencing. Ma'am, your expert opinion.
So actually the answer is not here. The answer is none of the above. So spinomuscular atrophy is basically caused by deletions or duplications in the SMN gene. And the test of choice would here be MLPA. And MLPA is like a sophisticated fish test. So you need to know what you're sending for. But at the same time, it can be much more broader and much more robust and specific than fish. So for conditions like spinomuscular atrophy, Duchenne muscular dystrophy, your choice of test would be MLPA. And it also helps to pick up conditions with methylation abnormalities. In fact, it's the only test which will not only detect the disease, but also give you the mode in which this has occurred. So whether it's uniparental disomy, whether it is imprinting, etc.
I'll just quickly add, we often see for Prader-Willi suspected case, clinicians are still ordering fish. But fish will miss 30% of the cases of Prader-Willi, and the test of choice is in MLPA. We just take that and quickly move ahead.
Yeah. So with that, we go to the last case of this presentation. So we have again two babies. One baby who was born in 2012 and the second one was born in 2017. The phenotype is mentioned that the children were floppy at birth. They had club feet, muscle weakness, respiratory distress, myopathic faces. The CPK was normal, but the EMG showed changes of myopathy. Both these siblings expired in infancy. So as I told you, in 2012, they had done a clinical exome sequencing where the result was normal. And in 2017, they did a broader test, that is a whole exome sequencing, and they found the result as variant of uncertain significance. So my question to the audience is, what does variant of uncertain significance mean? One, the disease may occur, disease may not occur, evidence is uncertain, and all of the above. Your time starts now. I think think the audience is becoming very smarter. 75%. So since we are running short of
Yeah,
time,
very
directly
quickly.
we'll go for
Next
the
slide, yeah.
expert opinion.
So when we do these sophisticated tests, microarray, NGS, answers are not always in black and white. So it could be clear-cut positive, what we say as pathogenic or likely pathogenic. It could be clear-cut negative, what we call as benign or likely benign, which of course won't get reported. The problem happens, the first comes when there is a variant of uncertain significance. But just the way in the preceding session there was radiology, we understand that every radiological finding is not of significance, and uncertain significance is uncertain. It can be associated with the disease, but what we often see is there's a hurried labeling to the child based on an uncertain significance, which should not happen. It may even be that this is a false positive, it's a distraction, and the evidence is uncertain. So which is why all of the above is correct. How do we solve these VOUSs, variant of uncertain significance? Very broadly, there are 4 things we keep in mind. Clinical correlation, lab and ancillary correlation. So clinical correlation, if I would have got a VOUS for Duchenne muscular dystrophy, I know this is not the case. Lab correlation, say if I get an uncertain finding for thalassemia, I know I just need to go back and look at the hemoglobin electrophoresis. Is it matching, not matching? Third thing is clinical evolution. Maybe when you look at the child again, look at the family again, few months, few years later, the pieces may fall together. And last part is genetic evolution. So the data, which is uncertain in 2012, 17, often gets reclassified with time as the information collates, as evidence increases. And this is exactly what happened in this case. If we can play the video, this mother, when she came 2 years later for actually planning another child, she had this symptom of sign of myotonia. And we can understand that this is a maternal myotonia. Her 2 children probably had congenital myotonic dystrophy. The answer was not on Zomato, not on Google. It was mom's homemade dal and rice, which means that the test is something very different from what the whole exome can pick up. All of the genetic errors, the magic mantra is not whole exome. These disorders, congenital myotonic dystrophy, Fragile X, Huntington, these are errors of trinucleotide repeat, where a sequence of the nucleotide is getting triplicated abnormally. And the test of choice is a very cheap TP-PCR based test. It's a test which is used in trinucleotide disorder specific to the disorder that we're ordering, very cheap, hardly 5 to 7,000. And this is what gave us the answer. And now we know that it is getting transmitted from the mother. There is a 50% risk of recurrence. Next slide. So we are, and actually, interestingly, when I was preparing this case, even that uncertain variant has got downgraded to being benign in 2023. So you see, this is a perfect example of how clinical correlation, evolution of phenotype, and had we labeled that uncertain finding as the thing, and the mother would have opted for prenatal based on that, there would be a shock waiting for everyone, basically. So we do not base major clinical decisions. Should I do a bone marrow transplant for a disorder that's showing a variant of uncertain significance? No, unless everything has really been proved. So major decisions, prenatal, major surgeries, major transplants based on uncertain, avoid. And that is the last slide, that how, what all will whole exome sequencing miss? It's not the Brahmastra that will cover everything. Smaller deletions, duplications, intronic errors, methylation errors, trinucleotide repeats, mitochondrial DNA. Again, mitochondrial DNA mutations, there are nowadays some labs which do offer whole exome that cover mitochondrial mutations. Order it if that's on your differential list. Otherwise, you need not go for it. Next slide. And I think that is what the message we need to take is that next generation sequencing still needs older generation clinical skills, bedside, phenotyping. Without that, we are often going to hurriedly and wrongly give a wrong diagnosis and unknowingly sometimes even cause harm. Just one quick association between how phenotype affects the genetic yield. When there are lesser than 5 meaningful phenotypic terms provided to the lab, the yield of the genetic test is between 15 to 20%. Same patient, same lab, If the number of terms are more than 25, the yield goes up to 45%. So the meaningful phenotyping, it's not just about, I feel it is this, we order a test. The thorough phenotyping is very, very important. And I think that is the final slide. I think there's nothing more. Yeah, we
Yeah.
can just take the conclusions.
So with this, I would request Dr. Ami to give the carry-home messages.
So like we saw in the different case scenarios, I think what we both agree and what we all should realize is the basic theme is clinical phenotyping. In each of the scenarios, we had some diagnosis in mind to begin with the testing, and that is very, very important. Now, once you have a diagnosis in mind, you also know what is the genetic change that you expect. So for example, when you're thinking of Down syndrome, you know that you're thinking of, trisomy 21. When you're thinking of, say, a scenario like what Dr. Shruti had presented, where there were two different deletions, micro deletions, duplications which were there, that is when you would opt for a chromosomal microarray. So you're looking for a copy number change, but at a much finer level. Then when you know that it's something like a SMA or a Duchenne muscular dystrophy, where you have a diagnosis, you want to aim it specifically, but you know that it's going to involve a bigger gene, and that's why FISH may not be sufficient, and that's why you opt for a MLPA. Sanger sequencing is generally used for family screening nowadays, and also for conditions like thalassemia, where we have certain set of specific changes known for a specific gene and which is common in the population. Next generation is a broad-based test. I will not go into the details of what it includes, but what Dr. Shruti mentioned, there are certain things which even a next generation sequencing test, even something like a whole exome sequencing would miss. The pointer here is whenever whole genome comes into play, we know that a lot of deletion, duplications, trinucleotide repeats would be included. And like she mentioned, certain conditions, triple nucleotide repeat PCR is important, and that is, again, you need the clinical diagnosis before you order that. So all in all, genetics is not a single answer for everything, and you need to have a clinical diagnosis to choose the ideal test so that it is both cost effective and efficient enough to diagnose. And lastly, VUS is not a full stop, it's not a red signal. It just means you need to re-look at the case which is there. Thank you.
Thank you very much.
I think that was a very, very well played Jenga. Thank you so much for such an excellent session. I hope we now know how to choose our move more wisely in a Jenga. Can we have the presentation for the next session? Yeah. So with this, we move on with our third scientific session for today. Our third session is titled, Our Search Engines Under the Lens. And for the same, we have expert faculty, Dr. Camilla Rodriguez, Madam. Madam is consultant microbiologist and chair of infection control at Hinduja Hospital and Medical Research Center, Mumbai. We have expert faculty Dr. Tushar Maniyar. Sir is head of Department of Pediatrics at Nanavati Max Super Speciality Hospital, Mumbai. And to moderate the session, we have Dr. Nehal Shah, consultant pediatrician at Saifi and Rukshmani Lying in Hospital. May I request the experts and the moderator to come on the stage, please.
Thank you, Amrita. So the rise in antimicrobial resistance is predicted to cause more than 100 lakh deaths per year by 2050 unless steps are taken to prevent this looming crisis. Microbiological culture remains the gold standard for the diagnosis of bacterial, viral, fungal pathogens. However, conventional tests and the antimicrobial resistance pattern takes 48 hours or longer. Rapid diagnostic tests are urgently required to guide the appropriate antimicrobial therapy, thereby improving patient outcomes and slowing the AMR development. So now this is the point. There is so much of aimless aggression and anxiety when we are lost. Should I order these multiplex PCRs, rapid diagnostic tests, rely on serology? Or should I be a conversationalist where I will sit by my clinical diagnosis, my clinical acumen, and only then the dilemma, be part of the herd that is strongly clinically oriented. So go by the clinical situation, go by the clinical history examination and then decide, or support the group who swears by the labs. So you may just order the tests and probably read out the reports and then take a choice. We certainly need to strike a balance. So with this overview, let's begin our today's session. Case 1, a 4-year-old male child got with history of high fever, cough and cold of 4 days duration with no improvement to symptomatic treatment. Today on day 5 of presentation, he on clinical examination is febrile, tachypnic and has bilateral auscultatory findings, so of course requires admission. What is the best next action besides antibiotics and supportive treatment? Add oseltamivir, send the respiratory multiplex PCR and then decide the treatment based on reports. Start antibiotics along with oseltamivir and in case of no response, then send the multiplex PCR panel. And your time starts now. So we see the results. So majority, half of them are saying start antibiotics along with oseltamivir and in case of no response, send the multiplex PCR panel. A quick raise. We have a very interactive and enthusiastic audience. So somebody who can defend why they selected the third option. Anyone, please. 50% has voted. Somebody who has to say why. So are we going to wait for another 48 hours, delay the diagnosis, delay the definitive management, cause anxiety on the parents? Nobody from the audience? Okay, sir, Dr. Tushar Manyar, sir.
So I have too many of my teachers sitting across and that too in first row, so I am nervous. But the good part is I would say any of these three would be appropriate depending upon what is the further scenario. If the patient is in a situation which is non-critical, is going to be in the ward and not in the ICU, and cost is an issue, I would add oseltamivir and not along with antibiotic and supportive treatment. On the other hand, if the patient is affording, I would go ahead and send multiplex PCR and start oseltamivir. But definitely not wait for the report to start oseltamivir. Once I have decided to start the oseltamivir, I would start it and not wait for the reports to come. The last option being, if I start antibiotics and oseltamivir and no response, I would send multiplex. That would be generally my last choice.
Madam, would you like to comment on this?
2 points. One is, we live in a world where we have double standards. The double standards are that if a patient is affording, the sky is the limit. That's the whole problem. So, for example, if in our hospital, every employee gets free tests. So every employee gets a biofire, whether it is indicated or not. So I think at this point in time, we have to be really clear that when we order an investigation, what is the pre-test probability? And we need to hover around the intermediate pre-test probability. So in other words, when I order this test, am I going to really change anything or am I not? So in this situation, what would I do? I would just wait. I would also look at the patient's pocket. To be honest, I'm also double standards. And if he could afford, I would probably send off a multiplex PCR. Again, multiplex PCR will go into the huge issues that it has. Yes. But on one hand, it has really been a paradigm shift. No longer is microbiology 3 days, it's 1 hour. So if you're going to start antibiotics with oseltamivir, wait, it's just an hour away. In an hour's time, I mean, how cool is that? You can get, assuming you're in a perfect world, patient can afford, there are no issues, and you are thinking of it could be a flu, it could be something else, I would wait for 1 hour. Believe me, we're giving a turnaround. We do these biofires, blah, blah. We do them round the clock because we believe the only advantage of these tests is time, is turnaround time. So if I can give you the test in 1 hour, wait, I will tell you, if I can, what it is.
So we understand that majority of the times in a general pediatrician's office scenario or ward scenario, when we're not looking at a criticality, it's better to go by clinically, start treatment, and probably then take a choice of whether we want a test or not. So
Yeah.
I want to add.
Just as what ma'am said is, if the patient is in the ICU, then my requirements and my categorization very different. Then I would go ahead, not worry about the cost. Because it's actually, you have to look at cost in multiple ways. And you know, we have been giving examples from morning. If you have a stock portfolio and one share is doing good and the rest are doing bad, you are going to look at your overall portfolio. If you try to save on BioFire, if you are not saving on BioFire, suppose you're spending on BioFire and saving the patient's ultimate ICU stay by even 1 day, where the studies say it can be more than 2 days, and even reduce the antibiotic duration by a few days, you would more than offset the cost of the BioFire. So we need to look at cost in a very different way altogether. Also, when we talk about cost, ma'am's talking about BioFire, and that is what we would do when the patient is in the ICU and critical care. But many times you have patient in the ward or outside, and then you have some other panels which are non-BioFire. Their specificity, sensitivity is a little lesser, but I can still do away with it because my cost is less than 50%. And the turnaround time is 24 hours versus 2 hours, 1 hour or 2 hours as for BioFire. So we need to make choice depending on the situation.
Thank you, sir. So in this patient, the report was positive for adenovirus. So, madam, what is the specificity, sensitivity of this report to decide now on stopping antibiotics? How specific is the report? How do I go by?
If you look at the various viruses, now just sort of to give, sort of an introduction, there are 2 types of biofires, if I can speak on that. One is the respiratory biofire and one is the pneumonia biofire. They're 2 different biofires. The respiratory biofire is for upper respiratory tract infections and kind of focuses more on the viruses than the bacteria, whereas the pneumonia biofire is actually for hospital-acquired infections. I haven't ordered it. I don't do that test because the issues that I don't believe in, which maybe I can tell you why. But I kind of am okay with the respiratory biofire because I think that it's giving me more information on what I cannot do in terms of cultures. So one, you're saying that this is adenovirus. Now, when you look at the respiratory biofire panel, it has so many viruses. Now you have to think of, oh my gosh, there's so many viruses. What do I do with them? Adenovirus, there are 3 viruses that can be associated with either they continue to be in the upper respiratory tract without meaning anything. They may be just asymptomatic colonization. And those 3 viruses are rhinovirus, bocavirus, and adenovirus. So these 3 viruses, when you isolate them, you've got to be really sure, is it really causing that infection? And adenovirus, when it causes an infection, is really a bad virus. Adenovirus not only causes upper respiratory tract infection, it causes cystitis, it causes gastroenteritis, it causes conjunctivitis. So which serotype of anyway, we're not worried about the serotype, but we've got adeno. Now, is it going to be an asymptomatic colonization? I think in this case it well might be. Is it going to be a long-term shedder? Is it going to be a co-infection? It could still be a co-infection. And is it going to be a super infection? So there are 4 parameters you would look at when you decide what you're looking at, what you've isolated. I would say currently, put my money, I would do all CRP, I would do CBC and say, is it kind of looking like a viral infection at all? So I think at that point, as of now, I'm not too fussed about the adenovirus because I think he'd be much sicker. Another issue is adenovirus comes in epidemics. It's associated with hospital-acquired infections because it remains on surfaces for ages. So somebody touching here, you get an adenovirus. So it really causes a lot of epidemics in hospitals. Now this little baby has come from outside. There's no chance of him getting a severe nosocomial infection.
So the commonest adenovirus that we've been seeing, madam has very beautifully told us this message, that it could be a normal commensal, it could be a super infection, it could be a severe infection, it could be no infection at all. So again, we are boiling back clinically. And sir, then, would you stop antibiotics or would you continue? Of course, this is a very
again,
critical
at the
question.
cost of repetition, what is your pre-test probability? Did you anticipate a viral infection at least? I'm sure we are not going to anticipate adenovirus as such. But the most important factor is going to be whether I have or some of my colleagues are seeing more of adenovirus. Only then, I think we have all seen this adenovirus coming in last 6 months. Before that, we have hardly seen a report positive for adenovirus. So that would be important. And again, adenovirus has been reported with co-infection in 20%. But as we have been taught by our teachers, co-infections or super-infections occur after the primary infection. So if my primary infection is adenovirus, there has to be sufficient time for secondary infection to occur. Answering your question in one line, I don't think if my X-ray is clear, that means no consolidation, then I could stop antibiotics.
Sure, sir. Madam, could you tell us some laboratory parameters that can suggest infection with atypical organisms? So here we are going away from our specific microbiological test. Some routine circumstantial evidences that can help us to suspect and diagnose an atypical organism.
If you're meaning the 3 atypicals, that is Mycoplasma,
Yes,
chlamydia, and Legionella,
Yes, madam.
they come with walking pneumonias. If this kid has a pneumonia on X-ray, these are walking pneumonias. I would go more clinically. Does he have a sore throat? Does he have a low-grade fever? How low is, how much is the fever? And generally, these atypical pathogens come with a preceding they look like they're viral. So from a lab perspective, I'd look at the CBC, I'd look at the CRP. I'd look at PCT if we can.
So a little non-specific on that, right, madam?
Absolutely.
Sir, would you like to add on this?
So again, simplistically, cough more than tachypnea, I would think of atypical. Tachypnea and very little cough, I would think of bacterial to start with.
Sure, sir. So then what is a better option? Since we know that there are no laboratory tests which will help us a circumstantial evidence to suspect an atypical organism, order a respiratory panel for a definitive diagnosis when I'm really thinking about these, or simply administer an empirical macrolide to cut down the cost and the other factors?
So here, I think the answer is quite simple. I don't think I've ever ordered a respiratory panel for an atypical Mycoplasma upper respiratory infection.
Right, sir.
If I'm looking at lower respiratory, anyway, my throat swabs are going to be useless. I'm not going to do them. And sputum in children is anyway extremely difficult to get, a genuine sputum. And atypicals do not generate that much sputum. So all in all, I don't think that is of any value.
Sure, madam. Madam, would you like to?
And Neil, just one more point. Mycoplasma has been shown to be in Finland, in Denmark, I think in the Scandinavia, in 21% of patients, they were happily carrying Mycoplasma with no untoward effect. They could detect it by these PCR. So do I really want to go up that way? I wouldn't do it.
Sure. So moving on to one-line answers to these multiple questions, madam, comes in analysis of multiplex PCR panels. We are primarily looking at the respiratory panels right now. Are the results influenced by the site of sample collection, sir?
Yes.
So could you?
Especially in newborns and very small children, most of them are not able to get right nasopharyngeal secretion, even through the oral route.
Mm-hmm. Okay, sir. Madam, what is the ideal temperature and duration of the holding time of the viral transport media after collection?
I think COVID has done something really good. It sort of taught us how to collect samples for these panels. And to be honest, before 2019, nobody knew RT-PCR. It goes on very, but suddenly it's become the corner street lab is doing it, and it's really good. I'm so happy that the whole technology has been extended. That has been a huge advantage of COVID. VTM, to be honest, we had our VTMs which were going expiry. Nobody was bothering to send samples. We were getting throat swabs just plain. So VTM is a must because it allows the virus to remain stable. And the ideal temperature is regrettably just 2 to 8. You have to maintain it at 2 to 8. And if you want, like Brajesh, he's not here, but he tells, keep the sample. Later on, I may think of something. So if you're going to keep it more than 24 to 48 hours, it has to go at minus 70. Mm-hmm. So more than 48 hours, I'll keep it in my lab fridge. But if I want to store the sample for anything subsequently, a month later, 2 months later, just keeping it in the fridge and doing the test is of no point. You have to store it at minus 70, and ideally a nasopharyngeal is the best.
So for a clinician, after a swab, immediately in the VTM and put it at a temperature of 2 to 8. Right?
Yeah.
Would antibiotic administration influence the reports, sir?
No.
Okay, sir. What sample can be collected from an infant? You said, but what is the alternative?
So I mean, generally we collect oropharyngeal only because in infant it's extremely difficult and traumatic to collect from nose.
Sure. What is the sensitivity and specificity of the panel, madam, overall?
Overall, I'd put it in the 90s. 89, 90 would be the sensitivity, and specificity is generally much better than the sensitivity for all these PCR panels. Again, if you, I find because BioFire is so expensive and it covers 23, 43 targets, blah, blah, if you have some indication of what you're suspecting, hone in for a single plex PCR. If you think the mother has influenza, the maid has influenza, then just ask for an influenza test. Don't waste money on doing everything because you'll get some 2 pathogens. Oh God, what am I going to do with that? So try and focus in on a single plex PCR.
Any factors for false positives and false negatives?
Absolutely.
So
because they're so sensitive, we're going to see the best part of these tests is their sensitivity. The more sensitive a test, the more the false positive. And the in literature, when you look at these tests, they do have false positive because their comparators are so kind of poor. We're looking at comparators with culture, we're looking at comparators with other that have not reached up to speed. So false positive is there and false negatives clearly depends on what it's targeting. If that target is not in the panel, it will be a false negative.
So madam, like a urine culture where we have a colony count, we quantify. Is there something like that for these tests also? That if I'm looking at maybe my next question, so can we differentiate between a colonizer and pathogen? So is there some quantification which may put me higher up on saying that yes, this is a definitive report that I'm looking at?
I wish I could lie to you and say yes, but there is no test. Okay. There is no way we can differentiate between a colonizer and a pathogen. Okay. And we have something known as, for the respiratory, for the pneumonia panel, we have something known as bins. These are semi-quantitative bins by which they say 10 raised to, anything more than 10 raised to 3.5 log is a pathogen or is significant. But you know what? We did an analysis when we got some 200 panels just to analyze. And we found in my hospital, it takes me 4 hours for the sample to come from the 7th floor to me. Because Maushi went off, somebody went off, so the transporter had gone to have tea. 4 hours. By that time, every Acinetobacter, every bug worth its salt has multiplied already. So my quantitation is not going to be up to speed. So I really don't believe in the quantitation, and I really don't believe that there is any way I can differentiate a colonizer from a pathogen.
I think the next question, madam and sir had already spoken how to interpret the report of multiple organisms. So definitely we are going on. A clinical suspicion, upper respiratory, lower respiratory, viral versus bacteria. Madam, win 2 sentences. I know this may be a little elaborate. Does the quality of the test run in a particular lab influence the results? So we are in awesome, we are in a closed compartment, and we won't mind if you can just spell out.
I don't know how to answer that. I think even I'm subject to compromising. These tests are so expensive. So what I like best is when a test takes into consideration that a quality control sample will be automatically done. I don't have to waste money on adding a QC sample, on adding a positive control and negative control. For example, you look at Gene Expert. It has quality control built into the cartridge. So I'm not fussed about a Gene Expert, whether it's done in Timbuktu, whether it's done in my lab. It's going to be right. Otherwise, it won't run. So the best kind of test that you can do is something that incorporates the positive, the intermediate, all the various levels of controls into the test, where it's not left to the laboratory and to decide, chalo, aaj thoda costly pada hai, itne samples aaye aaj, can I compromise on one negative or positive control? It should be inbuilt, and that's the best kind of test you can do, which is why Expert is like a better test to do. Similarly, respiratory BioFire, quality control inbuilt.
So 1, 2, 3. Considering all the factors discussed above, which clinical scenarios justify a respiratory panel in your experience? 1, 2, 3.
So in my OPD practice, if I have a family with high-risk member, then I would go ahead, my threshold of doing a precise test for influenza or COVID is going to be higher. If the patient is in the ward and I have time, I may not spend for a BioFire, but go for a slightly lesser respiratory panel where it will give me predominant virus answers at half the cost. And if the patient is in the ICU, then cost hold no bar. We go for everything at its earliest, and it's like your first slide, aimless aggression. Yeah. It's not really aimless, but you are in critical care, you don't have time. you'll go ahead and do whatever is best available.
Sure.
Dr.
So
Nehal, we
moving-
have 10 minutes more.
Yes, yes. So moving on to the case 2, 6-year-old male child got with history of high fever for 2 days and convulsion with altered sensorium on the day of admission. CBC showing 16,400 differentials, MP negative, CSF is 280 cells, 80% neutros, protein 80, glucose 50, MRI showing a diffuse cerebral edema and diffuse altered signals intensity. Your next best action would be IV antibiotics, IV acyclovir, send the meningitis encephalitis panel, and all of the above. Your time starts now. Probably thought this, expected. Majority of the people are on all of the above. So, sir, would you like to just comment on that? This is not.
Yeah, so even without the MRI, I would say the last option was the correct option. Because any child who you suspect as meningitis or encephalitis is a critical condition, time sensitive, and no waiting, start both antibiotic, acyclovir, and send for the panel.
Sir, so this was the report of that child. As we can see, it is negative for everything. So in that case, the question would be,
Yeah.
Madam,
So
how is, yes, sir.
Okay.
Yes, sir,
Sorry,
please.
sir. I just wanted to say that if again cost was not an issue, I would not go for this panel. I would go for BioFire of ME panel. I think ma'am can elaborate better on that.
Madam, please.
I think here I wouldn't stint on a meningitis encephalitis. Here, this is a serious infection. I would go for a panel here because, I mean, let's face it, culture takes 2 days. This gram stain is on antibiotics is dismal. So here I really wouldn't stint. But having said that, there's some issues with the BioFire or any viral multiplex panel is that if the viral load is low, you can miss it. So we've had issues where BioFire actually was negative, and when we went for a singleplex PCR only, and the clinician kept saying, no, I think this is Pakka HSV. And we were so shocked to see that BioFire was negative and HSV was positive, the singleplex. Because the low load sometimes doesn't pick up when it's multiplex. We're trying to get, khichdi of everything, and we may miss it in a low load. So definitely in a CNS panel, I think the good part of the CNS panel, especially for bacteria, it's harboring 3 more very important bacteria. Listeria, which is often missed. E. coli in babies definitely, and group B strep. So it picks these 3 up, in addition to the 3 trinity of meningitis, pneumonia, and H flu. And among the viruses, apart from the 5 herpes viruses, which it picks up, it also does enterovirus and parico. So it's kind of a good panel to do because it's really looking at a battery of herpes viruses. Again, herpes viruses, remember, there's a huge issue of latency. Latency, where's Rajesh was, we've had 2 cases of his which were HHV6. Oh my gosh, what are we going to do with HHV6? Remember, it gets incorporated into the chromosome. It doesn't mean anything if the patient is not immunocompromised. So you have to, at each level, understand what the test is meaning in terms of the kid that you're looking at. If he's not immunocompromised, I would scoff at an HHV6. I wouldn't bother. Similarly, one more fungus, that is Cryptococcus neoformans. We've had situations where crypto neoformans may be missed on a BioFire, but guess what picks it up? That silly little crack test that we do, which is so cheap, it hardly costs, I don't know how much, 200 rupees. And that crack test, it is a Cryptococcus antigen, we just dip in the ICT, picks it up, and the BioFire has missed it on, and it's known. If you look at literature, it can miss it. So remember that when you're doing a test, you have to understand what you're looking for and what is the sensitivity of that particular panel. But let me tell you, I'm particularly pretty pleased with BioFire meningitis panel. Sterile sites, much better than respiratory and pneumonia.
Right.
Sterile sites, when you get something, you've got to really think about it. Also, another issue is that it's not telling you sensitivity. But it is telling you that there is a bug, especially when there is an antibiotic. So that's huge advantages. For N meningitis, we recently had we could, meningococcus positive, we could do chemoprophylaxis of the whole family and close contact. So there's sort of advantages to do these tests. Cultures was negative all the time, So there have been paradigm shifts, no question about it. And I think the meningitis encephalitis panel has advantages.
So madam has already answered what I was asking. What is the difference in between interpreting the CNS panels versus the pneumonia panels? Since it's a very sterile and closed environment, so anything that you're going to pick up is definitely going to be of significant importance in treating. Madam, just a line, any special precautions while collecting the CSF sample? Any particular amount,
No
transporting
medium,
or it seems?
no VTM please, no
Right.
VTM here.
Right.
And CSF, always if you can get it to the lab, even not 2 to 4 degrees, we're not fast. And never ever put cold for a sample that you're intending to culture. When you're going to send a CSF, Mumbai temperatures are nice and hot, they're almost culture temperatures. So don't put it into cold because it will kill Haemophilus. It may kill meningitis because those are very, very subject to temperatures. Send it in nice hot temperatures to us for CSF. Another thing is when you're inoculating it into the bottle, we really like it when you inoculate it in the bottle on site. Don't put ice in that bottle. See, we get sometimes the Bactec bottles come with ice all around it and we get, oh no, what have we done? It doesn't matter, we can still take it out and restart the whole thing, but CSF, room temperature, hot Mumbai temperature is great for CSF. So just send it like that.
Thank you, madam. Madam, 2 lines on this Malditoff, which is the new multiplex PCR types. Just 2 lines so that they know what is Malditoff and whether we are doing it really.
Malditoff is actually not a molecular test, it's a proteomic test. It's nothing to do with genes. It's basically a matrix-assisted laser desorption ionization. Basically what it does is, it takes the bacteria. I need a culture to isolate. As far as you guys are concerned, Malditoff doesn't help you. It helps me a lot. Why? Because I take 15 minutes to identify any bacteria that I've grown, any fungus that I've grown, any blood culture that's come positive, 15 minutes and I'll tell you what it is. So it doesn't tell sensitivity. It just tells me what bug I've got and the name of the bug. It doesn't tell me how I'm going to behave, whether I'm going to behave badly or well with an antibiotic susceptibility test. It tells me, yes, this is this bug, and it tells you to 99% accuracy, which is why people who are using Malditoff are now spewing out wonderful names, which I have to quickly Google because I don't know it myself. So it tells you with 99% accuracy only the name. So what it does, it actually ionizes the culture you've put on a small matrix. It ionizes it the laser ionizes it, and then on the base of mass to charge ratio, it moves through a small channel. And depending on its weight, as it's got vaporized, each organism, each one of us, if we could be Malditoff, would have a certain characteristic proteomic signature that maps to the reference library that's in the machine and tells you, yes, this is Staph aureus 100%. Right. This is Streptococcus 100%, but stop there. It doesn't tell me whether it's an MRSA, it doesn't tell me whether it's VRE, it just says, yes, this is it. So imagine, we used to take one whole day to identify the bug, 15 minutes and I'll tell you what it is. So it tells me the name of the bug. It doesn't do anything for sensitivity.
So for a clinician, we should know that there is something called as Malditoff, which is going to give us quick, 100% accurate specific results, and we can ask for that. Sir, 1 line. So as a general practicing pediatrician, what are the other practical implications of sepsis and other multiplex PCR panels that are available for use in pediatric infections, practically? And when have you ordered? Just 2 lines, sir.
So you mean the blood-oriented multiplex PCRs
Yes,
for
sir.
infection?
So it could be, sir, so GI panel, sepsis panel.
I've never ordered a GI panel.
Okay.
But sepsis panels, yes. Malditoff, as you can call it, the gold standard for me as a simple clinician is Bactec or Bactalert, whatever you're using. And what you grow from there, then I leave it to my microbiologist. And depending upon the urgency of the situation, we'll ask for Malditoff or not ask for Malditoff.
So we have only 30 seconds, rapid fire, last question. We are moving our search engine from microbiology to serology. Which of the following tests are nearly diagnostic for that infection? Leptospira IgM, Brucella IgG, Wheel Felix test for rickettsia, EBV, viral capsid antigen, IgM, none of the above. So we commonly order all of these. So which of these are? Sorry, your time has started already. हो गया चलेगा. Wow, madam and sir both are going to be happy. So, yes sir, so please, last comment.
In a given clinical scenario, I'm happy to accept EBV on basis of EBV, VCA, IgM, and I don't need to always go for a PCR. That's about it.
And the rest as madam, please.
Leptospira IgMs, 5th to 7th day, a good test, not so bad. PCR is fine for the initial part. Brucella IgG, in a patient who's burnt out, many days have passed of hepatomegaly, arthralgia, fever going low grade. It's not so bad. I wouldn't say none of the above yet. Wheel Felix, good rule-in test. It gives a lot of rule-out test. It gives a lot of false positives because it's protease antigens. But it would tell me if it is positive, I need to go for a specific test for rickettsia. VCA, IgM, good test. Not so bad for a infectious mono.
Sure. And then we have, this is again not working. So we have take-home messages, but all of these are going to be provided in the Pearls of Wisdom booklet, which you will get it only at the end of the day. And it's all clinical that madam and sir have already explained here. So thank you very much for that patient hearing. Thank you, sir. Thank you, madam, so much.
Thank you, sir. Thank you, ma'am, for that excellent session. Now we move on to the most coveted, prestigious and honored session for the day. We have the Dr. S.M. Merchant oration. And for the same, I would now like to invite Dr. Nehal Shah, Secretary of the Indian Academy of Pediatrics, Mumbai branch, to introduce Dr. S.M. Merchant oration.
It is an honor and privilege to stand up here today to introduce someone who has been a giant and a true master for pediatrics, Dr. S.M. Merchant, sir. And on this occasion, I would also like to acknowledge the presence of Dr. Vandana madam, Dr. Prem Seth madam, Dr. Kumud Mehta madam, who have been very closely associated with him, and of course, Dr. Sonu Udani, who's come here as a special guest for the recipient of the oration. So if you were successful, somebody along the line gave you some help. There was a great teacher somewhere in your life. Dr. S.M. Merchant, sir. A tribute from his pupils, his colleagues, friends, and the pediatric fraternity of India. Better than 1,000 days of diligent study is one day with a great teacher. A great teacher is like a candle. It consumes itself to light the way for others. Dr. S.M. Merchant, a legend in his own lifetime. He began his association with B.J. Wadia Hospital for Children at Parel, Mumbai in 1949 under the guidance of Dr. Sansgiri. He rendered services as honorary professor, dean, and then honorary research director. He contributed to the growth of B.J. Wadia Hospital with his imagination, foresight, enthusiasm, and unceasing efforts. A person of eminence, abilities, and vision, he extended encouragement, support, and freedom of expression to his junior colleagues in academic pursuits. He was innovative and growth-oriented, initiating the research laboratory and the growth of super specialities in his institute. He had a talent and love for teaching and for imparting clinical skills and bedside clinical art. He was loved as a teacher, friend, philosopher, and guide to many students and colleagues. His colleagues at B.J. Wadia feel a sense of pride, privilege, and happiness in having associated with him during their lifetime. Many honors have been bestowed upon him. He was elected Fellow of the National Academy of Medical Sciences, Indian Academy of Pediatrics, and American Academy of Pediatrics. Dr. S.M. Merchant was a visiting professor at the Johns Hopkins Children's Hospital and many institutions in India. He has many guest orations, publications, and presentations to his credit. He has served on many national committees, including the ICMR. The Dr. S.M. Merchant oration was instituted as a tribute to his work at the Embicon in the year 2002, and today is the 12th oration. His pupils and colleagues join in paying their best tribute to a person whose virtues they strive to emulate and whose academic trends they attempt to uphold. Dr. S.M. Merchant will continue to inspire several generations of pediatricians and teachers for many, many years to come. Good teachers teach. Great teachers inspire. Thank you. With this introduction, I now invite President Mumbai IIP 2023, Dr. Rajesh Chokhani sir, to kindly come up and introduce our most esteemed recipient for this oration today, Dr. Rajesh Udani. Thank you.
A very good morning to everyone. Almost about 3.5 to 4 decades ago, when Dr. Rajesh Udani sir and Dr. Sunu ma'am had returned from the US and they had not yet started working in India, they came to JJ. We were students there and Udani sir was requested to take a class for us. We were presenting a case of what looked like chorea to us then, and in those days, our 5 differential diagnoses for chorea were rheumatic chorea, rheumatic chorea, rheumatic chorea 5 times. And if anybody asked us what was the 6th cause of chorea, we would say, I don't know. And then Dr. Udani took the class for us. He gave us a differential of Haloverden-Spatz disease. And we were zapped. We said, "Arey yaar, this was something to be written only in theory papers. Does all this exist?" And it is from that time that over the years, Dr. Udani has opened a whole new world of pediatric neurology. He's opened the door of pediatric neurology for us. And we have just been looking at this like a zapped pediatricians over these 3 years. And our concept of child neurology has moved on from just TBM, and that occasional GBS to now mitochondrial disorders and demyelinating disorders and epilepsies and epilepsy surgery and so on and so forth. He has an enviable CV. I mean, any one of us would love to have such a CV. So a brilliant academic career from Grand Medical College, diplomate of the American Board in Child Neurology as well as Clinical Neurophysiology, a huge body of clinical and research work, a crusader for the prevention of perinatal hypoglycemic damage, early diagnosis of autism and so on and so forth, an expert on several panels to give guidelines in child neurology, publications, awards, prizes, orations, he has it all. But what I would like to particularly mention is that he is a top-class clinician. I had a child who was diagnosed with a neurometabolic disorder in his first illness at about 2 years of age, and unfortunately that child succumbed in his illness. The mother was about to deliver the next child, and she said, I want this child to be seen by the best in this city as soon as he is born, or he or she is born. And right from the maternity home, she went to see Dr. Udani, asking him whether there is any fear of the same problem, whatever. I don't know what he answered about that, because obviously he couldn't say anything on day 2 for a normal newborn. But he told them, this boy has an inguinal hernia, please go and get that treated. And they were not told that in the maternity home. So that's the top clinician that Dr. Udani is. Of course, he's a great teacher. He's been a very frequent teacher at our Thursday clinics by Amdekar sir at Sion. And I've seen with my own eyes the passion with which he demonstrates clinical science and explains the physiology behind everything. And it's as expected, the students are all totally enthralled. Of course, he's a great speaker, and he's come a long way from the Udani versus Udani situation, which I will tell you, to the present day. So I am told that at one of the Pedicons at Bangalore many years back, Dr. P.M. Udani, his father, was speaking, and the next talk was Dr. Rajesh Udani. And for those of you who know Dr. P.M. Udani, sir had this small defect of transgressing time, and sir would take longer and longer. So Rajesh Udani was telling his friends and colleagues, ki please tell my father to stop, otherwise there will be nobody left in the audience. But from that, today is the situation where if Rajesh Udani is speaking in one hall, no other faculty accepts a talk in the adjacent hall. He has gigantic attributes. He is known as a gentle giant by his friends. He is very, very understanding. Ask any of his students. He is a foodie who loves to cook also. He is a very caring family man. And the residents at Hinduja Hospital are testimony that even when his father, Dr. Udani, was unwell, or his beloved and our beloved, Sunu ma'am, is unwell, you can see the tension on Udani sir's face. So a very caring family man. He has a never say die attitude. He just doesn't give up for any patient. Just this Thursday, we had an online discussion with another group of doctors. I think Dr. Manglani madam is here. So there was a child who was post-transplant who had some neurology complication, was admitted at Hinduja, and there was a big online discussion on what more can be done. Everybody was brainstorming. I mean, it's so easy to say that this child is almost comatose, brain dead, and forget it. But Udani sir doesn't give up. He has this unlimited energy, and his Tuesday free clinics at Hinduja Hospital were the first resource for all public hospitals, JJ, Vadia, everyone, Nayarsan, to send their patients for his neurology opinion. Even pediatricians have attended that OPD and learned so much from him on those Tuesdays. And it would start at 8 o'clock and would never end. So he had tremendous energy. And finally, he has a genetic defect which I would covet for. His anger gene is only deleted. So, friends, presenting to you the multifaceted gem of a person, Dr. Rajesh Udani. May I request him to now come on the dais and deliver his oration.
Good morning, everybody. Little difficult to follow that. I mean, those kind of accolades, I don't think are even half true. But I thank you very much, Rajesh, for even giving me that very, very difficult to accept accolades. You know, this is one thing I wanted to correct in his introduction. I'm a foodie who loves to eat. I mean, the only thing I could actually make is a cup of tea. And once I tried even fried eggs, and I made a mess of it. So I think a foodie who likes to eat, yes. About Dr. Merchant, I knew him initially when I was not in pediatrics. He used to come to my house for parties. I used to be the unofficial bartender in my teenage years. And Dr. Suren Merchant, Dr. Shantilal Sheth, Dr. Manar Wagle, many people used to come, and the most charming, easy, friendly and pleasant person was always Suren Kaka. And you could see, what a social animal he was. Everybody loved him, especially the ladies, actually. But he was really something else. And then when I went into pediatrics, I realized what kind of, academician he was. He was a pioneer. I mean, the first generation was Dr. Koilo, Dr. Ramesh Sansgiri, and they were in rival hospitals. And then you had Dr. Merchant, Dr. Udani, and many others. And the second generation were the ones who really built pediatrics in the city of Bombay, both legends. He brought Wadia to a tremendous hospital. Institution building was his forte. He got super specialists in the sense he actually told people to become specialists, subspecialists. So at his time, we had Prem who was here, neonatologist, Kumud Mehta, nephrologist, Meena Desai, endocrinologist, and everybody was sort of made to enter into subspecialties, which is very much unknown at that time. Everybody was a general pediatrician. So I think he has built Vadia to what it is today. And I'm very happy to tell you that I go there regularly, and now the free clinic is not at Hinduja, it's at Vadia on Tuesday. So I think this is something which, I'm very, very honored, very, very privileged to give a talk as a Dr. Suren Merchant tribute. So I was wondering what to speak in this. Orations are very difficult. And it's basically what do you speak on, what excites you, what is you passionate about. And being overexposed the way I am, much of my talks have been heard by many people, and I always wonder what to speak on. So, I just start off with this particular saying, which is very pertinent to this talk. A superior doctor prevents illness, the mediocre doctor attends to impending sickness, and the inferior doctor treats actual sickness. And unfortunately, most of us, including me, is in the third group. And this is something which has bothered us, because over the years, child neurology tests, diagnosis, all these things become irrelevant. Diagnosis was so much fun before, you used to get passionate, here test karo, wo. Now we know that these things are important, of course, but how do you prevent things from happening? How do you improve general populations of children? Look at India. It is the fastest growing among 7 largest emerging and developing economies according to the World Bank. And as you can see, we are rising above fast. So what do you need? Most important resource is not financial, it's not military and all that kind of thing. What you need is human resource. And this is critical. And look at what that human resource should have. Education, skill, and should be productive. And who can that be? Not old fogies like me, but young people. And that's what India's demographic dividend has been talked about for so many years, that 142 crores, 68% are young people. So we need these young people to be at their best. They should be good enough to look after India in the so-called Generation Alpha. I didn't even know there were so many generations, but the present generation is called Generation Alpha, for your information. Now, could we help in a small way, pediatricians? So our responsibility is to our patients' cognitive and mental health. We must prevent, minimize brain injuring conditions. But more important, I'm not going to discuss minimizing brain injuring conditions, but correcting factors for cognitive health, improving learning, etc. So how do you improve learning at our small level? So let's look at learning disorders. So prevalence of specific learning disorders amongst primary school children in a South Indian city, this was a little way back, was about 15%. Average kind of thing, according to, even abroad, you have these kind of figures. Maybe slightly higher than what was estimated earlier. But look at the education report from rural areas. I'm sure you must have heard of this annual status of education report in 2022 in the rural areas. Most of these children are enrolled in government schools. The dark blue represents government schools. And therefore, they are the bulk of the demographic dividend. And of course, majority of them, some of them are in private, but majority are in government. Now you look at the reading and arithmetic levels of these boys and girls in grade 5 and grade 8. Okay, this is the time when they're about to go for their 9th and 10th, so at that time. And it's quite abysmal. Grade 5, boys and girls, around 40% can read grade 2 level. So grade 2 level is achieved at grade 5 in 40%, and in ability to do division is in about 26% to 27% in grade 5 and about 45%. So the majority of them are finishing their 8th year being illiterate, literally. And this is different in different states. The red bar tells you the all India, which is 1 in 4 children can read a sentence in English, 2/3 of them can comprehend what they read. Private schools fare better, but not too much. In northeastern states, north states do a little bit better. Look at the trends over the years. So this has been going on since 2012. If you look at pre and post pandemic, there's been a slight decline from 44% to 38%, obviously. So basically, grade 2 reading is still not less more than half the people we have in our country. What about over the years? These are the different figures for different years from 2012. And you see more or less is slightly improving, but not too much. And over the last 2-3 years, obviously because of the pandemic, it's gone down. Well, let's look at this little boy. Please give me full volume. I'm asking him to read in Marathi. Fairly fluent.
कुत्र्याच्या पिल्लाला त्रास देत होती. कुत्र्याचे पिल्लू बेदरून गेले होते. ते रस्त्याच्या
Then I ask him to read in English.
पाण्याच्या डब्याकडे
ठीक आहे अभी ती वाच.
So many things were different when Grandpa was a boy. He never showed a nose and seldom had a toy.
अच्छा त्यांच्या मराठीमध्ये सांग काय बोल. So many things were different म्हणजे काय. Grandpa कोण आहे? आजोबा. So when grandpa was a boy म्हणजे काय? नाही म्हणजे काय टोटल काय सांग. So many things were different when grandpa was a boy म्हणजे काय?
आणि boy मुलगा.
नाही grandpa आणि boy कुठला boy? तू. हां तर मुलगा कुठला आहे? He never saw a movie म्हणजे काय? मराठीमध्ये सांग ना. He never saw a movie. I didn't want to embarrass him further. मूवीचा मतलब काय पिक्चर आहे. And he seldom had a toy म्हणजे काय? नाही माहिती ना. ठीक आहे. So you see the problem. It's very obvious. And when I do this in front of parents who come to me for learning disorders with all sorts of tests from different hospitals, with saying this is this, you wonder what they mean. So let's just go through what we need to know to speak. And this is a very complicated diagram. You may get a little worried. Phonetics, phonology, morphology, syntax, semantics, pragmatics, discourse. So I'll just tell you what each one means. So what is phonologic awareness? What is phonology? It's basic speech sounds. What is awareness of that? So CAT is actually ka-ata. You all know that. And you basically join them unconsciously in your head and you say cat. What is morphology? So words. So you're going back to the cat only. Cat has actually two meanings. Cats. Cat means single cat. S means multiple cats. So you're projecting that meaning to the person who's listening to you. Syntax. So it's the arrangement of words and phrases, sentences, which is called grammar. Correct? All of you know that. To make a sentence which will hold a specific message. So let's look at these two examples. I have a cat as a pet is different from I had a cat as a pet. So then you come to the next one, the semantics, which will help you understand those two messages. So the first sentence actually, that pet is an animal who I love and who lives with me. How do I say it's love? Because it's a pet, so I usually love my pets. And who lives with me, who's still alive. Second sentence, I had a cat in the past. So obviously you must know these words if you want to understand a language. Then pragmatics, things like metaphors, similar sounding words, etc. So let's use of language in a particular context. It's raining cats and dogs. All of you know that means it's raining heavily. It doesn't mean that it's raining actually literally. But a person who's that poor boy would not be able to know this. Discourse, storytelling has to be something which you learn and then you make a story, beginning, middle, and end, which makes sense. That's called discourse. This is how language develops in the first few years of life. And how do you read? This is then transported to reading. So you have to first speak the language, and then you read. So first you decode. Basic language skills, you decode. And that means you break up the word in your mind, ka-ata. And now people are using phonics in urban schools, private schools mainly, to teach them. Otherwise, there's sight reading, where you showed a picture of a cat, C-A-T, cat, and you remember that cat. How many words can you remember? So you don't break automatically. And then you have to have reading comprehension. So you have to understand, and that will depend on your vocabulary, which you've learnt when you were speaking, when you're learning the language. Verbal memory, so you must have a store of words in your temporal lobe. So you know which words to use when. And then you get a mental image. So it's very well, these are the centers. You see the word cat, your vision has to be good. You decode, so you do phonologic processing, visual processing, all those things. Then you identify the word. Then that thing goes to the temporal lobe, which word is the actual name of that thing. And then a mental image forms in your brain, a cat. And that's how you read. Okay? Now let's come to this boy again. Huh? What is your name? He knows his name. Which city do you live in? Huh? तुला माहिती नाही पडलं तर मला सांगी मी समजत नाही. Which city do you live in? तू कुठल्या शहरामध्ये राहतो? अहमदनगर. Who lives in your house? He's 11 years old, huh?
Ramdas and Mira.
Who's Ramdas? He doesn't know his brother. And who's Mira? He doesn't use the word brother or sister. तुझ्या घरीमध्ये कोण कोण राहतं?
Yes.
The mother or parents always help. Huh? Yash? ती कोण आहे? Perfect in Marathi. Perfect. काय होणार नाही. काय होणार नाही. काय होणार नाही. आणखी कोण राहतं? Sometimes it's so cruel that they start crying. रामदास कोण आहे? Because they realize how little they know. मीरा कोण आहे? ठीक है. So how can you understand what you read if you cannot understand what you hear? Okay, okay, so let's come to the third thing. All over the world, you go to your own language school. So if you're in Japan, you don't go to English school. You go to Japanese school. Over here, English is a link language. It's a kind of a stepping stone to further improvement of your lives. You know, everything will get better, jobs will be better, etc. So it is the parents feel that, and therefore the English is the education aspirational language. Unfortunately, that's not true. So this is a very nice study. Primary schools, low socioeconomic group in Hyderabad, are they ready for English medium instruction? So 90 children, grades 4 to 5, in government schools in Hyderabad. And the task was simple. They were asked to read something and retell the story in English, or if they preferred, in Telugu. Okay? Clear things were found. Oral English vocabulary skills far below level. Needed to read class textbooks. So the present class textbooks can't be read by them only. Limited range. So whatever range they had of words to retell the story was very limited. That's called lexical diversity. In both languages. Reading skills were better than reading comprehension. So reading skills are what? Like the first time he read. And that is called fluency. That's called decoding the language. That they could read. 98% letters. Now this is grade 4 and 5. 76% words. So 25% couldn't even read words. And 71% sentences. So early reading needs decoding skills. I already told you that. Only 31% understood what they read and 60% scored 0. So what do you do? What do you do? Because the exam is coming. You learn it by heart. And parents say that. कि memory बहुत अच्छी है, वो सब पढ़ते हैं, फटाफट होता है. By heart. By heart means समझा नहीं है, लेकिन by heart मालूम है. And later reading, therefore, depends on comprehension and oral vocabulary. What about how do you learn language? Exposure to English. And family में तो कोई बोलता नहीं है. Peers don't speak in Hindi, in English. Most of the friends are speaking in local language. And teacher talk is all mostly in local language. Because even the teachers are not very fluent in these government schools. And there were many, I've seen documentaries where people are actually shown that the teacher herself has problems in reading and writing. So what the final thing was, children from low socioeconomic schools in government English medium instruction struggle to understand the English textbooks. Now this new education policy has come up. And that is, I think, the best news of 2020 when it actually came up. These three other funds, we used to have 10th plus 2. Now we have 5 plus 3 plus 3 plus 4. So what is this? So the foundation years, the medium of instruction according to the government now will be till grade 5, home language, mother tongue, local language or regional language. So the regional language is English, fine. Some northeastern states, the English language. Gujarati ma Gujarati, Gujarat ma. Tamil Nadu, Tamil, whatever. And if you are a Tamilian who's living in a Hindi state, Hindi, there's a local language. Because they know that. Early oral exposure to other languages. So you start teaching English early, but as a subject. And you learn how to speak, not how to read. And when we taught, you don't need a medium of instruction to be English to learn English. Like we learned Hindi in school, we learned Marathi in school, there was no problem. And teachers have to be encouraged to use bilingual teaching, so keep translating and all this kind of thing. And in the preparatory and middle schools, you learn to read. So everybody knows that young kids, because of too many synapses and all that, they can pick up languages very fast. Reading and writing should be after grade 3 in English or in other languages. Textbook should be in multiple languages. Use of technology. And finally, the goal is to learn 3 languages. So I think this is a great step forward. Another thing which was a little difficult to understand in 2010 was when this came up. Right to Education Act, effective from April 1, and promotions, because everybody was so tense about school exams and all, so sabko promote karo. What happened? First of all, there was not enough infrastructure or money to give everybody the right to education. You know all the state of the schools all over the place. You know, half the time the teacher is not there, the school is closed down, this, that. I'm not talking of urban India, please. I'm talking about the bulk of the population. School dropouts, many illiterate. In this new policy, you are evaluated at standard 5 first. And if you are not up to date in standard 5, then you're given a second chance to appear, and then you're kept behind. Your strengths are, your weaknesses are seen, and you're given steps to increase those, help those weaknesses. And this is very important. So you'll identify, otherwise you have people who are coming out illiterate. No, all this is very fine. This is the government's job. Hum kya karenge? So I think this is what we can do. How to boost early language? Early language is in the first 3 or 4 years of life. How do we learn language? Interactions, communications. So parents should do this. Ask questions, read to them, sing together, play word games. Most of you have done that. So why but people are nowadays screens doing all this. This is the problem. Talk to your kids about daily activities, books you read together, all these kind of things. And for medical part, identify early language delays, because these are the ones who are going to have particular problems in reading. So if you have that early language delays, then you send them for evaluation and treatment. Remember, expose them to English if it's possible. Somebody in your elder boy can speak in English, you talk to them in English. Usse hi baat karo. Second thing is a very important thing, which I've given a little talk before on this, but I've just sort of updated this, is sleep. So how do you improve your cognitive health? Now, adult studies have shown there are lots of psychological issues which are improved by sleep. Attention, mood, judgment, motivation. Very, very standard things been known for years. Immune functions and metabolic are systemic effects. And if you have chronic sleep deprivation, you can get all these conditions, including Alzheimer's. So one of the theories of Alzheimer's now is that if you don't sleep enough, you might be gaga at the age of 60, 70. It's happening to me, at least for sure. But just generally I'm saying, so please sleep well. How many hours do you need? I mean, these are just ranges. Infants, toddlers, preschoolers, school age. But essential, infants 12 hours, toddlers 11 hours, preschoolers 10 hours, school age children 9 hours, teenagers 8.5 hours. 8.5 hours is the cutoff for a pediatrician. At my age, 6 hours. At older age, 5 hours. Wo chalega. But remember, your sleep, most important part of sleep is to memorize, to learn. And that's important. And teenagers, of course, I'll tell you what are the sleep times in India. Country-wise data, India is second to Japan. We are the worst sleepers. We sleep less sleep compared to the rest of the world. The best is New Zealand. कहा कुछ करने का नहीं है, सब सो जाते हैं. And 40% of Indian children are known to have sleep problems on questionnaires, compared to only half that number in developed nations. And the adolescent data from India is very bad. 14 years, that's about 9 standard, 8 hours, 17 years, 7.5. So both are sleep deprived. And if you look at 58 hours per week as the time to sleep, almost 90% of these patients, of these children, are not sleeping. And what are the reasons? Delayed bedtime, early wake time. School jaldi karne ka hai, lekin raat ko late sona hai. And what is the reason? It's not only screens. It's parental pressure for studies, tuitions. They come home at 9:30, sleeping in. There's no time for leisure. And therefore, what it leads to is all this: academic underperformance, poor attendance, increasing depression. Depression, by the way, is very common in adolescents. I think we are missing all of them many times. And then many of them are drowsy, and if you're drowsy, you really can't attend to your schoolwork. So how do you memorize? How does sleep help memory? Some of you may have seen this slide. The frontal lobes, the one which are colored over here, are called the anterior frontal, and they register. So whatever I'm saying, I hope, is registering in your frontal lobes. Then there's consolidation. So what is consolidation? There's short-term memory. So whatever you learn the whole day, that gets transferred to your hippocampus, which is in sleep. Everybody thought sleep is a passive process. It's absolutely not. It's the most active process there is. And then, because of repeated registration and repeated memory traces being formed, it goes into long-term memory, and then you can retrieve it from the neocortex. For verbs, for example, words, it will go into the temporal association cortex. For pictures, it will go into the occipital association cortex. For the motor skills, it will go into the frontal motor cortices. So all these are muscle memory, all these things are important. And this is how it happens because slow wave sleep, which is delta sleep, you know, it's not the REM sleep, it is not the early part of sleep, it's the sleep when it's delta sleep. That is the time nothing is going on in your brain. No dreams, nothing. So there's enough time for that memory and all that stuff to go on into the neocortex. That's how we remember. So does sleep really help us remember what we learned? Absolutely. If you look at these two human volunteers, one was allowed to both learn the same thing, one was given sleep afterwards and one was not. And the one who slept has better memory of those syllables several hours later. So I think it's important to sleep after this lecture. But not during it, I hope. Anyway, other theories how sleep helps learning. You heard of synaptic pruning? You see, over there is a kid, he's got a lot of networks, lot of synapses, because we are learning much more at that time. And then adults, whatever is strong in those synapses, whatever you learned again and again, those synapses are maintained, and those other synapses are forgotten. So you need to prune them. You don't want to overload the electrical system. Right? You don't want to overload. So when does this happen? In sleep? It also happens in adults, by the way. There's so many unnecessary things you hear in the day, get in the day. One may be this lecture. But that also, you know, you want to, basically that pruning of unnecessary information happens in sleep. And if that doesn't happen, then this is the problem. And the maximum synaptic pruning occurs between 2 years and 10 years. And there's something called resetting, rebooting in computer language. Every night, emotions, you've been a very bad day, rough day, depressing day. You reset in the night. You get up the next morning, you're fresh. Everything seems positive. If that doesn't get disturbed, you get problem behaviors, hyperactivity, inattention, all these kind of things. And can you believe it? Shortened sleep time actually leads to decreased structures, volume of structures. So much research has gone in this. All these areas in cognition, which are dealing with cognition and with behavior, these areas actually become less over time. And this is one of the theories of what happens in Alzheimer's disease. So there's no question, there are lots of literature on this: worse cognitive functions, behavioral problems, mainly attention and executive function, mainly in the frontal lobe. So what is executive function? Reasoning, planning, problem solving. And funnily enough, we thought memory was an important thing, but in children, there is no significant effect on memory or intelligence. So it's basically your attention and your executive function which suffers. And your behaviors. So you become more hyperactive, it is called externalizing behaviors, aggression, impulsive. Sound like ADHD? Yes, it is. And internalizing behaviors, which happens more in older children, depression, anxiety, etc. And all these factors, remember, it's not just intelligence which dictates school performance. It's everything. Your attention, your intelligence, your memory, and your behavior, which dictates academic performance. And this is long lasting. And the funny thing is the parents also become depressed when this happens. So what we should inform our parents at every visit, ask about sleep routines. Kabhi sota hai. So mundane, so boring. It is very important. Inform about sleep needs at different ages. Make sleep routines a habit from the toddler stage, not later on. You can't switch on and off. The body is a clock. It takes time to adjust. So sleep before 8 o'clock if you're below 9 years, and sleep 9 o'clock if you're above 9 years. I want to ask you, how many of your kids slept in this time? Almost none, no? This is the problem. And then you avoid how to help this? Don't sleep in the afternoon. Because they make up their sleep in the afternoon, but the sleep in the afternoon is never good enough. You don't get delta sleep in the afternoon. So what you need is avoid long daytime naps, especially late afternoon. Increase leisure time. Kids are not having leisure. They are just study. And come a little early from your work. Ulhasnagar, by the way, nobody comes early. They come at 1 o'clock. So the parents and the children all sleep late. And sleep in a separate room, not possible in India, but if it is possible, desirable. And finally, no caffeinated beverages and no screens. So this is a program which was done in France, where they educated the school, educated the parents and the kids. And they found that the total sleep time after 1 year actually increased and remained increased. And this led to a lot of improvement in the executive function and the attention and all that. Now this is a very peculiar pediatric problem, sleep disordered breathing because of tonsilloadenoids, hypertrophy. And there's something called sleep disordered breathing, which is either snoring, but without any major sleep. You do a sleep study, you don't find much changes. It's just snoring away. And sometimes this may give rise to learning problems in attention, aggression, depression, same symptoms. And the other one is OSA, obstructive sleep apnea, where you have, and this happens with, you actually get lower IQ with this, besides many systemic problems. So what do you do if you have OSA, 100% tonsilloadenoid? Don't try medical treatment. However, if you have only mild or moderate sleep disordered breathing, primary snoring, they have normal sleep studies. So people say, kuch mat karo. It'll go away, give this, give that. So the study was done where some 105 patients were actually going for tonsilloadenectomy according to the ENT surgeons. They had scheduled it. And these guys said, okay, we'll just assess them before and after. And they found that many of them had these 30% had ADHD symptoms. And 1 year post-surgery, everything had improved, including excessive daytime. And you can see the red, this is the normal, this is the red, this is the apnea, hypopnea. This is patients in different behavioral and different cognitive performances, everything improved after 1 year. So I think even patients who are anybody who's open mouth, I was told by an American ENT surgeon, if your mouth is open when you sleep, that's the indication for doing something. We don't ask our children also, is your mouth open or not? I mean, you don't know, the child would not know, but the mother would know. And that very often comes with snoring. So you must find out about this persistent snoring. So mild, moderate sleep disordered breathing also may be useful to TAR if you have these behavior symptoms, etc. Screen time. We know we don't get enough sleep, electronics, etc. And if you look at the, from studies, majority of them at younger age, older age, almost all of them are sleep deprived. They have delayed sleep time, shortened sleep time, etc. And this is more if you're using a mobile or a computer, and less if you're watching TV. You also must have noticed that TV dekh ke so jate hai. But if you're using a mobile or using a laptop and doing work, you won't be able to sleep. That's what I was doing last night. I couldn't sleep till 3 o'clock. Anyway, so this is what has happened. One of the events which has happened in the pandemic because of increased screen time is this condition called virtual autism. So you have classic autism, which is basically very early symptoms and all that. And then some of those patients are very mild. You can't even recognize them in the first 1 or 2 years. And then during this thing, this has made news all over the world and now even in India. And that is possibly caused by increased screens. Now reasons, all these are very obvious. Meal times, while you're doing your household chores, keep them calm in public spaces. During meltdowns, very often he starts crying or something, mobile is given. And sometimes even during bedtime, which makes his sleep time worse. And if you look at, we did a study in Hinduja Hospital, and you find, and these are the use of mobile media in different neurodevelopmental disorders. So in autism, CP, epilepsy, etc., ADHD, and the highest was ASD. So the amount of mobile media watching in ASD is very high. Now whether it's causative or not is very difficult to say. But look at the symptoms before the pandemic and lockdown and after. So for example, this was behavioral score. This was before everything went down. Language, also, sorry, this is supposed to be language, even that's gone down. So essentially, things became worse. This was another, so now the problem is, okay, autism, TK, if he's got autism, don't give him screens. But what about normal kids? What happens to the language skills? This is a lovely study on 260 normally developing children. And what they found is, the longer the time of screen times, this is the young patients, the 8 to 17 months. They don't have much of language. They have communication by gestures, pointing, this, that. So that line is going down the longer you're on the mobile or screen. And later on, between 18 to 36 months, your vocabulary develops. Again, that line is going down. So essentially what you're saying is that language skills, both non-verbal and verbal, are affected by screen time. One of the reasons why there's delayed language. And of course, other things also happen. Social interaction is poor, emotional regulation. So essentially what the American Academy has said, of course, and we should follow, I think we've also made the same guidelines, below 2 years, no screens, including television going in the background. Because that is a distracting thing, and because it prevents you from interacting with your child. And after that, use 30 to 60 minutes, possibly interactive, not otherwise. This one study I want to show you. There are 3 types of screen times. There are guys who go up to about 60 minutes and then remain stable. There are other kids who use about 150 minutes and then slowly decline. And there are late, so people who are going straight up to 230 minutes. So in China, they studied child-mother pairs between this, and at baseline, which is at 1 year, all have the same mental age. Lower score in the full-scale IQ in the early increasing and late increasing group. So these 2 patients actually had drops in IQ scores for up to 10 points. And the early increasing group, this one, had also severe behavior problems. So I think this also tells us there's enough data to suggest that screen times actually affect cognitive and behavior. And why? Why does it happen? See, this is a child, this is the prefrontal lobe which I keep talking about. It has to have connections with the posterior part. This is very important, and this is absent most likely in the early increasing group. Second reason is it interferes, excessive sleep time interferes with cognitive stimulating activities. So late increasing group, for example, when you're playing with your kid, reading is a very good method of improving your cognition and all, so that should be encouraged. Now the last part, deficiencies. So this everybody knows is initially thought to be some meningoencephalitis, infantile tremor syndrome, and then turned out to a B12 deficiency. And recently, a lot of work from Chandigarh has given some exemplary articles on what happens. So the clinical part, now they are saying you should call it infantile B12 deficiency and not infantile tremor syndrome. And you don't have to have tremors. That's why there's no point in putting a tremor. So in fact, tremors are a small part. PEM is the big, but these are the other things that happen. Regression, delays, microcephaly, skin changes, hair changes. And people do B12 levels and say that's enough. It's not enough. You have to have homocysteine and methylmalonic acid. Homocysteine may be easier to do, and that's high in 96% even when the levels are normal. Because even a single dose of a B complex will make the levels normal. And you get all these changes, myelination gone, cortical atrophy, and very severe cases you get changes in the basal ganglia which explain the tremors. And of course these are the changes which you get, knuckle hyperpigmentation. And this is again described from Chandigarh, a peculiar bat wing dystonia on recovery. So you can see they all become like this, like bat wings, and they remain like that for about a month or so, and then they improve after B12. So the question we have is ITS or infantile B12 deficiency a cause of isolated delay? So we did a study many years, didn't get published because it was not a positive study. And we found that we did idiopathic delays in breastfed veg cases and 18 breastfed controls. So those who are normal were controls. Unfortunately, the B12 deficiency, B12 levels, MMA, homocysteine were high in both. So obviously it was not accepted as a paper. And hyperhomocysteinemia in GDD infants less than 1 year was higher than the control. That's the only thing we got. And this is the time period of maximal brain growth and myelination occurs. And from Chandigarh recently, they've confirmed that healthy babies below 1 year of age, 40% of them have confirmed B12 deficiency. And if you consider homocysteine and MMA, then 75% and 100%. So this is the same study as ours. So most of us are B12 deficient. Believe me, most of you in this room are also B12 deficient. I've told my wife a number of times, but she doesn't believe me. So how common is it? Indian preschoolers, this much. India adults, this much. South India, little less. And because they eat a lot of, non-veg, I don't know. And in the other places, basically in Japan and all that, so most of our patients are falling outside the normal levels. And why B12 is, of course, animal foods, lacto-vegetarians. Funny part is even non-veggies hardly eat non-veg. Once a week on a tyohar or something they eat, once a week on Sunday. So it's only the Goans and the Muslims and some others who eat every day. And in Pune, for example, 70% had low B12 levels, high homocysteine, MMA, and methylcobalamin deficiency in pregnancy is linked to fetal deficiency, which continues because of breastfeeding. So what? We have low B12 levels. People are saying we have low vitamin D levels also. Does it make any difference? And this is an excellent study from Brazil. So asymptomatic infants, patients who you see in the well baby clinics, and they did a study of national Brazilian nutrition study, and look at the number of patients, 6,000, more than 6,000, and they found that the DQ, in normal kids also, the DQ falls over time. So at the age of 1 year, you apparently have a higher DQ in normal babies, and it goes down when it reaches about 36, 60 months. So it comes down like this. Now, if you have B12 deficiency, then that goes down further. So there is an association, this decline which is normal actually worsens because of B12 deficiency. So I think there's so much evidence now that there's no question that B12 is a very important thing for us. So why doesn't milk protect us? Boiling. We are the largest producers of milk in the world. Look at, we're way ahead of Europe. And yet, we boil all of milk. We don't use pasteurized milk very commonly. And boiling destroys it. And that's one of the major reasons. Of course, other thing is you're not eating non-veg foods. And this are some of the studies in India that more than 80%, this is again from Chandigarh group, remain delayed despite 6 months of treatment with B12. Maternal B12 deficiency, cognitive deficits in their 9-year-old children. And recent case control study shows a B12 status in ADD and ASD lower. So of course there was some talk about fortifying B12, but with rice and B12 in rice, but I don't think it's happened. So we should ask everybody about dietary. Is it vegetarian, non-vegetarian? How often does he eat meat? Supplement with B12 all mothers in pregnancy, especially if they're vegetarian, to prevent fetal deficiency. Continue postnatal, especially if the mother is breastfeeding. You know, remember, B12 might be responsible for mild delays. Many years ago, I forget the name now, Kapse, Dr. Kapse. I used to know him very well in Surat. I think he's passed away now. So he sent me a patient of mild delay. And I did all the tests and, kuch aaya nahi. So I said, we'll give physiotherapy and all this kind of thing. And he went back. And then he said, मैंने उसको B12 दिया, थोड़ा 2-3 इंजेक्शन दिया, वो तो उठ गया. First time I realized that just without any tremor, without any anemia, without any evidence of B12 deficiency, that was the first case I had where only delay was there, which was because of B12. Head growth could be suboptimal because of B12. So if you have a patient with B12, head growth is not good. Of course, if you take the head growth, that's important, we should do that. And don't forget to do a homocysteine if you are investigating. The thyroid sab karta hai, vitamin D level karta hai, calcium karta hai, and nobody does homocysteine. It's a little expensive, but do it. Don't do B12 levels. Do homocysteine. The last part is omega fatty acids. Look at the number of, you must have had medical representatives telling you all this. They sponsor our conferences. So they are called cognitive enhancers, omega fatty acids. And they have a lot of effect on the brain. And this is proven in animal studies, in function, in perfusion, and most important, in prenatal development, maturation. They increase synapse number and brain volume. And this is not just out of the blue. These are in animal studies. And animal studies have shown that you give them omega fatty acids, they actually improve in their cognitive and attentional tasks. Human trials, unfortunately, inconclusive. Some trials benefit, some trials no benefit. And there are many reasons for it, different criteria of inclusion, small numbers, doses, etc., etc. Most people are not telling exactly what the preparation is also. This was the meta-analysis which was published in 2016 of all. And the only difference in this was they did levels of omega fatty acids. And they found that in typically developing kids, the levels of DHA, which is the important one for brain development, was high. ADHD, it was much lower. ASD, it was below now, very, very much low. And when this study came about, I started using omega fatty acids in all my patients of ASD and ADHD. Believe me, it helps. Whether it helps because of other reasons, I don't know. But it seems to help. And if you look at scores on attention, so this is tests of variable attention, TOVA. And this is basically the levels. As your levels go up, your attention scores go up. And increase in ADHD symptoms with lower levels. So clearly there seems to be some effect on levels. Now whether these levels are doing anything, I don't know. All of you must have heard of CARS, the Childhood Autism Rating Scale. Lower levels of DHA correlate with higher CARS scores in ASD. So there seems to be some truth in this. And this is another study. I'm giving you studies because there's nothing more to do. I cannot give you a case to show this, but basically 3 major conclusions. That omega fatty acids improve clinical symptoms of ADHD. This is a meta-analysis. They improve cognitive performance, and this is a large effect. This is a modest effect, and youth with ADHD have lower levels of EFAs. So I think so does the dose really matter? Why is this literature so confusing? It's so good. Because when you analyze the doses in this meta-analysis, you find that the minimum dose to give is half a gram, if not a gram. And it has to reach a particular level of 6%. So I think that's the whole thing. So what should we advise? Maybe in ADHD, ASD, please use it, especially in young children when you don't want to use Ritalin and methylphenidate and all this kind of thing. However, cost is an issue. So if you want to use otherwise fish, maybe regular fish, that's also very expensive, and flax seeds, and at least 1,000 milligrams a day. In typically developing children, I don't think I would recommend it as yet. Consanguinity, it has a lot of problems. It's south is the highest, northeast is the lowest. Some things are declining. First and second cousins is actually increasing, but uncle, niece is declining. Muslims and Hindus are the most common who are getting married consanguineous. And main determinants were religion and cultural differences and not socioeconomic. And it's declining according to studies because of education of women. And this is just the studies showing different rates, very high in the south, but it's come down, very high in the west, it's also come down in 2015-16. And there are lots of ill effects. I don't have to tell you that. Monogenic disorders, complex inheritance, all these things are worsened by. So epilepsy, in fact, if you have a consanguineous union, it's twice as common. IQ points are lower, So what can we do as pediatricians to reduce? Legislation is obviously not in our hands, but it's not going to happen, There'll be all furor all over the place, all that kind of thing. So they've said that related marriages are void except if permitted by local custom. So obviously that is a self-defeating loophole. And obviously it's not feasible also. Better maternal education, I think many steps are being taken and this will hopefully yield awareness campaigns. But most important is pre-marital counseling. They come to you, your children you have been following since the age of 1 year. She becomes 18, 19, 20. They still come to you. They have a trust with you. You can tell them, no? In certain groups of, where the consanguinity is common. You can explain over time not to get married to your own cousin. So I think I just summarized there are many big little things which may help in India's Gen Alpha reach their full cognitive potential. Helping children learn, our approach to education should change. Lifestyle modification should also improve, increase total sleep time, etc. But remember, lifetime modification is a thing which nobody does. I've been told so often to exercise and diet. Hota hi nahi hai. So that's the problem. Lifestyle modifications are very boring, very mundane, they are not scientific. But they are what helps, and that's why counseling is more important. And look for these, in fact, don't look for deficiencies. Anyway, people give B12, vitamin D, uske saath mein B12 bhi de do, aur kuch nahi. Just last, I think my father was he helped me a lot in my MBBS days, taught me how to think out of the box. Singhal Saab was where I learned my neurology first. And my great teacher, Dr. Amdekar, is right here about rational thinking, how it helps. And a big thank you to the people I've had a good fortune to work with. These are my many fellows I've worked with over the years. Many of them have become very prominent neurologists in their own right and have spent 1, 2, 3 years with me in different institutions. So thank you for keeping me on my toes and tolerating my outbursts. I mean, that thing about anger is not in my gene. I think he's not seen me in my all my different avatars. So I think, and finally, I must thank my family. Now I've got a grand daughter. This is, of course, many years ago. Now she's about 2.5, a little more than 2.5, and she's blabbering. And I made sure of one thing. I gave her no TV in the first 2 years. I made sure she was given omega fatty acids. And finally, my beautiful wife. This was when the day when we got married. I think she's as beautiful as she is now. Thank you very much.
Shawl do, shawl do. ट्रे ले लो हैम्पर दे दो लास्ट में स्प्रे
This is a scroll of honor from IIP Mumbai to Dr. Udani sir. Dr. Vrajesh P. Udani. A leader is one who knows the way, goes the way, and shows the way, said John Maxwell. You have nurtured the field of pediatric neurology in India from its infancy and helped it grow to its present status. It is you who totally changed the pediatrician's perspective beginning 4 decades back and transformed their microscopic vision of pediatric neurology into a panoramic view. Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young, said Henry Ford. Your continued penchant for learning is an attribute that is in itself worth learning from. You are a master clinician who has kept abreast with the advances. You've been running fast enough to keep pace with the strides of technology. In learning, one teaches, and in teaching, one learns. Some teach from the books. You teach from your heart and from your experience. You have touched the lives of so many students, and by doing so, you touch the future. By sharing your knowledge, you have only multiplied it. Success usually comes to those who are too busy looking for it. Your sincerity and dedication towards your work and your patients has set an example for the next generation that is worth emulating. And yet, you have never blown your own bugle. Your humility reminds us that humility is not thinking less of yourself, but it is thinking of yourself less. True greatness consists of being great in little things. In spite of your position and stature in your field, you still continue to offer your services to the underprivileged sections. It speaks volumes about your compassion. In recognition of your immense contribution to the field of pediatrics, by bringing in and establishing pediatric neurology as a specialty, the Indian Academy of Pediatrics, Mumbai, is proud to present you with this scroll of honor on the 3rd of September 2023 at the awesome Embicon 2023.
Hold it and give it, sir. Madam, request you to please come here. And Madam, Kumud Mehta Madam, Prem Seth Madam, Dr. Vandana Madam, please. Madam, sir.
So now we'll be breaking for tea for 15 minutes. Students who are presenting posters, kindly be present with your poster at your poster site. The judges will be coming for evaluation. And delegates are also requested to have a look at the posters. They are in the behind the food area, in the open area outside. And students who are presenting oral papers, kindly be back on time because the next session will be on oral papers. Yeah. Request everyone who is standing to please be seated. We'll be starting with the session on free papers now. We have, I would request all the students who are presenting free papers to be present at the ahead of the seats. And I would like to welcome the judges for the free papers, Dr. Tushar Maniyar sir and Dr. Pavan Sureka sir. So we have our first free paper presentation by Arya James. May I invite her kindly on the dais to start a presentation.
Good afternoon, everybody. I'm Dr. Arya James. I would like to present this paper titled Utility of Microalbuminuria in Predicting the Outcomes of Critically Ill Patients Admitted in PICU, an observational prospective study at a tertiary healthcare center. I would like to go through these topics: introduction, aims, methodology, results, discussion, conclusion, and references. In critical care units, prediction of outcome of patient allows planning of early aggressive therapeutic interventions, optimum resource allocation, appropriate counseling of the family. Um, there is use of prognostic scores and mortality scores in ICU, which are cumbersome to perform, and multiple investigations are required to derive the values of these scores and predict mortality. The need of the hour is to identify a simple, rapid, and readily accessible parameter to predict prognosis of patients admitted to PICU. Microalbuminuria is defined as an albumin-creatinine ratio of 30 to 300 milligram per gram on spot urine sample. It is a predictor, it has been accepted as a predictor of vascular injury in adults with diabetes and hypertension since long, and it is useful in predicting mortality and outcomes in critically ill patients, and it has recently been investigated upon much more. The aims of the study was to assess the utility of microalbuminuria in predicting the outcomes of critically ill patients admitted in PICU at a tertiary healthcare center, and to determine the correlation of microalbuminuria with PRISM-4 score in predicting outcomes of critically ill patients admitted in PICU. The study design was a prospective observational study. The setting was at a tertiary healthcare center for over a duration of 2 years, and sample size was calculated to be 115. The children admitted to PICU at a tertiary healthcare center between the age of 1 to 12 years were included in this study, and exclusion criteria was said to be of age less than 1 year and more than 12 years. Patients with anuria, urological trauma, urinary tract infection with significant proteinuria, ongoing replacement therapy, renal replacement therapy, chronic renal disease, use of nephrotoxic drugs, and diseases leading to proteinuria were exempted from the study. The details were recorded in standardized, semi-structured, pre-validated case pro forma, and investigations were sent. Microalbuminuria estimation was done by immunoturbidimetric method, and sample was collected, a random midstream sample of urine within the first 24 hours of PICU admission, and outcomes were recorded in the form of duration of PICU stay, use of inotropes, use of mechanical ventilation, death or survival. Coming to results of the study, maximum patients who were enrolled to the study belonged to the age group of 1 to 5 years of 50.4%, and 5 to 10 years age group patients belonged to 44.3, constituted 44.3% of the study, and more than 10-year-old age group patients were constituted 5.2% of the study. Male-female ratio of the study was 0.82, and females constituted 54.4% of the study. And regarding the diagnosis of the patients in whom microalbuminuria was tested and further prediction was made, respiratory system constituted most of the patients, 17.4%. Which was followed by cardiovascular system, and then by central nervous system, followed by other systems. Outcomes of the study, outcomes of the patients were defined as first one was survival or death. Among the 47% of the patients survived, and 52.2% of the patients were non-survivors. Among those patients with microalbuminuria, 54 patients were found to have microalbuminuria, and among them only 52% of them did not survive, and only 2 of them survived. And among those patients who did not have microalbuminuria, 58 of the patients survived, and only 3 succumbed.
You have 1 minute left for your presentation.
Use of inotropes was found to be significantly higher in those patients who presented with microalbuminuria. Use of mechanical ventilation was also found to be significantly higher in those patients who presented with microalbuminuria. Mean duration of PICU stay for those who had microalbuminuria was 3.29 days, and those without microalbuminuria was 3.88 days. Comparative validity of PRISM-4 score and microalbuminuria in predicting mortality revealed that area under curve for that with albumin creatinine ratio was 0.972, and those with PRISM-4 score to predict mortality was 0.956, which reveals that microalbuminuria is can be compared to prognostic scores of PRISM-4 score.
Time is up for presentation.
Conclusion is microalbuminuria can be used as a parameter in predicting outcomes of critically ill children admitted to PICU, and it is comparable to standardized prognostic scores used in PICU to predict mortality. Thank you.
Over to judges for questions.
Thank you, Dr. Arya. Very nicely presented. I wanted to ask you, how have you classified multi-organ failure patient in your study? You know, you have written different systems, CVS, CNS. So if I'm sure quite a few of them will have multi-organ affection.
Yes, sir. Those patients who had cardiovascular, the patients who presented to PICU were almost bad patients who, with those patients who had a structural heart defect or who presented with shock were considered as cardiovascular, and those who had complaints pertaining to respiratory system, fever, cough, cold, and X-ray which was suggestive of pneumonia or any other kind, and then.
So, for example, sepsis with multi-organ failure.
Yes, sir.
Right?
Yes, sir.
How have you? That patient would go under which category?
Sepsis. There was a category named sepsis also, sir.
Okay.
For who could, when one system could not be
that is
alienated, and a generalized topic was given.
One more question.
Yes, sir.
You said microalbuminuria was a good predictor. Was it better in one particular system diagnosis or overall in all? Have you done a separate analysis of system-wise, or
No,
you have
sir.
taken all together PICU patients only?
All together, sir.
Okay. Thank
Separate analysis was not done.
Thank you, Arya. Good presentation.
Thank you, sir.
The point is, the microalbumin has been done within a short period of PICU admission.
Yes, sir.
After the report came, did you change any line of treatment? As you have predicted that microalbuminuria is related to severity of the illness, was the treatment changed after that?
No, sir. It was just an observational study. Interventions were not made during this study, sir.
I think your time is up. Thank you so much. May we have the next presenter now for oral papers, Dr. Rachit Mathur.
Good afternoon, delegates. I shall start my presentation on the topic early referral saves lives, analysis of malignancy in children. So the outcome of pediatric malignancy is significantly impacted by early diagnosis and prompt commencement of treatment. Many symptoms associated with childhood cancers are non-specific. Therefore, the diagnosis of cancer in children is uncommon in routine practice and might be missed. So delayed in diagnosis of a malignancy may lead to more advanced disease at presentation, leading to adverse outcomes. So timely access to a quality healthcare has become an increasingly important public healthcare concern over the years. So our study aimed to collecting the data or confirmed malignancy was analyzed in terms of the demographic profile, time from onset of symptom to referral and initiation of treatment, and the correlation of time of symptom onset to referral with outcomes. So the records of all children up to 18 years of age with a newly diagnosed malignancies registered to our center from January 2018 to July 2023 were reviewed with regards to the demographic profile, which consists of age, sex, and the resident, treatment received prior to referral, which consists of antibiotics, steroids, and supportive care. In supportive care, we include the blood products, antipyretics, and painkillers, and AKTs. Distance traveled to reach our hospitals, time from onset of symptom to referral, and time from referral to initiation of treatment, and the outcomes. Outcomes in the form of relapse, were alive and well, and expired. So a total of 146 patients were included in our study who fulfilled the inclusions criteria. So 48 patients out of 146 were lying in the age group of 6 to 9 years of age, and the 29 were lying 3 to 6 years of age, with the median age of our study was 6 years and 4 months, ranges from 6 months to 17 years. Male to female ratio in our study, as shown in this graph, is 1.4:1. 79 patients out of 146 were diagnosed with acute lymphoblastic leukemias, while AML consists of 29 cases. Likewise, Hodgkin and non-Hodgkin lymphomas are 10 and 6 respectively. So, median duration from onset of symptoms to referral, as shown in this graph, suggests that a patient with ALL, diagnosed with ALL, has a median of 30 days with a range from 10 to 65 days, while the patient with AML have a range of 30 days with a range of 10 to 15 days. Likewise, the patient diagnosed with Hodgkin and non-Hodgkin lymphomas have 50 to 16 days as a median respectively. So this graph depicts the duration from referral to initiation of treatment in a patient with AML, diagnosed with AML with a median of 5 days with a range from 2 to 27 days, and with a patient with a AML having the median of 6 days with a range of 20 to 22 days. Likewise, patient of Hodgkin and non-Hodgkin lymphomas at the median of 12 and 14 respectively. So 71 patient out of 146 was received prolonged course of antibiotic prior to the referral, and 11 patient has received steroid, which might have upgraded their risk stratification and worsened the outcomes. 64 patient has received supportive care in the form of blood products, antipyretics, painkillers, and AKT. So median distance traveled by the patient to report to our center was 405 kilometers, with a minimum of 2 kilometers and maximum of 3,060 kilometers. So 132 out of 146 patients adhered to our treatment, while 10% opted out in the middle, and 4 patients opted for treatment elsewhere. So 103 out of 146 patients were alive and well, while 29 patients were expired and 14 patients were relapsed. In the relapse cases, the patients who are alive are 3 and the patients who are relapsed and expired are 14. So we have made a correlation between the mean duration of the onset of symptom to referral and the treatment outcomes. We have taken 2 groups, the patient who are alive and well versus the patient who are relapsed and expired, and we found a significant correlation with the p-value of less than 0.05 with a correlation coefficient of less than 1. Thus, early referral impacting the survival. So, as shown in the Ishwat Ahmed et al., significant correlation was seen in overall survival, which decreases from 70.8 to 51.2, and increase in the relapse rate from 12.3 to 22% in a patient getting treatment before and after 6 months of onset of symptoms. Another study published by Abel Helu et al., patient diagnosed with ALL have an overall delay of 30 to 60 days from the onset of symptoms to initiation of treatment, experience more induction mortalities. So the conclusion, so delayed referral affect outcomes adversely. So the warning signs of pediatric cancer should be known to all healthcare professionals caring for the children, and accessibility to pediatric cancer unit in 2-tier cities may help in early diagnosis. So these are some red flag signs that we should know aware of, such as unexplained and prolonged fever, unexplained weight loss and night sweating, pallor, bruising or bleeding from any sides, lymphadenopathy with no signs of infections, abdominal lumps, eye changing in the form of white eye, new onset blindness and proptosis, and CNS signs with a persistent headache, vomiting mostly in the early morning, seizures or behavior changes. So bone pain and swelling, joint pain and limping gait and easy fractures are other warning signs that we should look for. Thank you.
Thank you. Over to the judges for questions.
Thank you, Rajit.
Thank you, sir.
Any study done for the reasons for delayed referral?
So some of them patients presented with non-specific symptoms. So they somehow receive a prolonged course of antibiotics, and few of them receive multiple antibiotics, different antibiotics for a prolonged period of time, like 2 to 3 courses also. And in some cases, the patient are not willing to come to the tertiary care hospitals. And in some cases, the awareness of the non-specific symptoms were not there, so they are referred late to our centers.
So, nicely presented. When you say delayed reference, it could be error, no, I wouldn't say error, but reason of commission or omission.
Yes.
Right? So omission, what you already described, commission has been steroids being given.
Yes.
You have not and majority of your cases were ALL.
Yes, sir.
Am I right in saying that if they have received blood products, even that would affect the outcome or risk stratification of those patients? Am I right or not? Am I not
So
correct?
that patient who has received blood products may increase the chances of their morbidity, as that blood products, the child with ALL received the blood products,
Correct.
have increase in the viscosities, blood viscosities, or there is more lysis of the cells, which may lead into the tumor lysis syndrome or some morbidities. So it will give more emphasis on that.
When you have given us the distribution, you have put steroids as one area.
Yes, sir.
Right? Antibiotics as one and
Yes.
supportive treatment as other.
Yes, sir.
Would it be advisable to separate blood products or certain specific actions or medications which would impact on the outcome of the patient?
Yes, sir. Apart from antibiotics and steroids, blood products and AKTs are also being impacted, and two of our patients of lymphomas have seen prolonged course of AKT, and they are given the AKT empirically. There was no clinical evidence or microbiological evidence of tuberculosis, but still the child is receiving AKT, and after receiving 4 to 5 months of AKT, the child ended up with our center, and we are diagnosed as a lymphoma case.
Okay. Thank you, Rachit.
Thank you,
Dr. Rachit.
Thank you. May we have the third presenter for oral paper now, Dr. Bhuvneshwari.
A very good afternoon to one and all. Today, I present the study of the impact of excessive screen time on childhood behavior, development, and nutrition in children from the ages 6 months to 12 years. There has been a significant increase in the accessibility of digital technologies, which is a worrying trend as it is responsible for the impairment in language, development, behavior, and physical well-being of young children. The AAP guidelines state that children below the age of 2 years should have none screen time at all, and only 1 hour for children in the age between 2 to 5 years. The onset of the pandemic has seemed to worsen the situation, and thus our study investigates the impact of excessive screen time on children. Our aims was to study the screen time profile in children from 6 months to 12 years of age and to evaluate the outcomes of excessive screen time on childhood behavior, nutrition, and development. The children admitted in the pediatric ward were enrolled in the study after taking the parents' consent, and details like the demographic characteristics, parental history, nutritional assessment, screen time duration, and behavioral assessment were assessed. The behavioral development was assessed using the strength and difficulty questionnaire. All the critically ill patients admitted in the ICU were excluded from the study, and the sample size was calculated to be 150. The observations and results were tabulated according to the following criteria. The mean age of the male patients was 5 years and female patients was 6 years. 54% of the children belonged to the age group more than 5 years of age. 52% of the fathers and 39% of the mothers had a high school education, while only 13 children had illiterate parents. 62% belonged to the lower middle class according to the modified Kuppuswamy scale. When we assessed the duration of sleep based on age, it was noted that the younger age groups had a tendency to sleep more than the adult study population, perhaps due to the lesser use of media devices. When we evaluated the nutritional status in children It was found that as the age of the patients increased, incidence of malnutrition also increased. 18% of the children above 5 years of age were obese and overweight. When we calculated the number of media devices in each household, the maximum number was 3, with the television having a higher percentage than mobiles. However, none of the children had a screen media device of their own. When we assessed the content of screen time, it was noted that majority of the children above 5 years had increased duration on the weekends between 1 to 3 hours, with a significant association present. Similarly, with games played on mobiles and computers, the majority were above 5 years with an increased duration on weekends between 1 to 3 hours with a significant association. Today, social media has entrenched the younger generation. It was noted that there was a similar duration on weekdays and weekends, but with a lesser number of children involved as compared to the other content. Physical activity was taken into consideration as the long-term use of screen media devices may induce obesity. The total duration of exercise was longer in the weekends by both the age groups. Lastly, and importantly, when we assess the behavioral assessment using the strength and difficulty questionnaire, it was noted that there were more of behavioral problems in the older children, maybe due to more usage of screen media devices. It was astonishing to see that 3.4% of the children had emotional symptoms, 11.1% had conduct problems, 8% had peer problems, and 9% had low pro-social behavior. If I would like to summarize my results, there was a statistically significant association between age and sleep duration. Excessive screen time has statistically significant behavioral problems in all age groups. The usage of screen media devices was mostly done in patients more than 5 years of age with increased duration on weekdays, weekends as compared to weekdays. Lastly, I would like to conclude by showing you this image. This image depicts the extent to which our children are addicted to social media devices. We all know that younger children benefit the most from live and dynamic interactions, but excessive screen time severely impedes this. The onset of the lockdown, online schooling, and restrictions have hindered parents from regulating screen time use. So today, we as pediatricians play a crucial role in creating awareness amongst our patients and parents alike, and restricting screen-based activities and developing face-to-face interactions as well as physical exercise to promote a healthy development in this digital era. Thank you.
Thank you, Dr. Bhuneshwari. Over to the judges for questions.
It's an interesting study. I wanted to know how much of screen time in the slightly older age group that you said maximum 5 to 6 years was school driven, meaning mandatory screen time, because a lot of school activities now happen on screen.
Yes, sir. When online schooling started, more than 5 years, approximately 10% of the children spend time watching their educational programs based off school.
Sorry, let me rephrase. I'm not talking about online school. Even in physical school that is currently on, good amount of material comes on screen, or some exams and other things that they have to do online.
Okay, while attending school.
While attending school. Do we have any, so what I'm saying is that you may not be able to control that screen time. So
yes, sir. So this is a multifactorial approach, as well as the parents, even the school authorities should be educated about the impact of excessive screen time. So accordingly, they should regulate the amount of screen time they are exposing their children to.
Thank you, Bhuvneshwari.
Thank you.
Good presentation. Is there any correlation of children of housewives and children of working mothers?
Yes, sir, that is a very pertinent question. As today, majority of, even in the lower classes, both the parents are working. So due to their increased work times, children are tend to expose to more screen media devices, either to keep them occupied and to keep them engaged. So it is relevant to know that working parents might have an excessive screen time on children as compared to the others. Thank you, sir.
Thank you. I thank the students and the judges for this oral paper session. We now have the next session, which is titled Common Beginnings, Uncommon Endings. For this session, may I invite on stage distinguished speaker, Dr. Raju Khubchandani sir, the founder of Pediatric Rheumatology. I welcome you, sir, on the dais.
Where is my talk? Okay. Coming this morning here has kind of rekindled so many memories that I'm reminded of that song, "Those were the days, my friend, I thought they'd never end." So, friends, it's really with that great sense of deja vu, if you may call it, that I like to refer to the time 2020 to 2023 and anything that happened before that as BC, before COVID. So, let's go back to the year 2003. There were two very important things that happened. Of course, there were several, but I just thought I'd remind you of two. One, the Iraq War, and the second, the coding of the Genome Project. Now, somewhere around that time, it was Embicon February 2003. So exactly 20 years ago. And I had just seen a few cases of Kawasaki before that and presented them at an international paper. So this was a kind of a medium vessel vasculitis, and it was pretty clear that we were underdiagnosing this entity, which led us to create a Kawasaki disease registry in Mumbai, and the rest, as you know, is history. I hardly get a referral for a child with Kawasaki. It is being diagnosed at the primary pediatrician level, albeit I have to say with some regret, probably overdiagnosed, even as costs of IVIG have come down. Let's therefore move a little fast forward and let's go to this group of disorders which are called autoinflammatory diseases. So like you have autoimmune diseases, which are disorders of adaptive immunity, you have disorders of innate immunity, which are called autoinflammatory disorders. Now the autoinflammatory disorders are classified into two types. First, the hereditary variety, which are called the hereditary autoinflammatory disorders, and then the acquired variety, or at least we think so today, acquired. Maybe X years down the line, Shruti Bajaj will tell you that this is the gene which is involved with this condition. But as of today, systemic GI, mind you, I did not use the word systemic onset GI, that terminology has changed. But for that, a separate talk and a separate invite by Rajesh and Nehal. Chronic non-bacterial osteitis, Behçet's, PFAPA, etc. Now, look at what happened at the start of the century. At the start of the century, these were the only 4 diseases known to man which belong to the category of hereditary autoinflammatory diseases. How much cost did it take to test for these? $1 billion. As I told you, the human genome was just being cracked. Today, how much does MedGenome or Strand or LifeCell or anybody do this test for? 15 to 20K, and that's about it.
So today, how many diseases do we know? Over 65. Okay? And now I'm going to talk to you, therefore, taking you fast forward. Here is a disease, and I've done a back of the envelope calculation. The gene frequency has been worked out by population statistics as 1 in 236. So the possibility of two people having this gene marrying each other becomes approximately 1 in 55,676. Now you look at that population, 1.4 billion, a figure that Brajesh showed you in one of his slides, and it shows you that we should be having somewhere around 25,000 such cases. How many do we have actually reported in India? 33. Okay? So, where are we going? Let's look at this case and you'll understand the story. Fever from 2006 to 2011. This child, I owe a debt of gratitude to Dr. Deepak Ugra. He was the one who referred this case to me to start with. Intermittent abdominal pain, needless to say, the surgeon sees this opportunity. Myositis, splenomegaly, very steroid responsive. So therefore taken so much steroid that he gets osteoporosis and a fracture of the vertebra. Mouth sores, scleritis, arthralgia, livido rash, no family history, no consanguinity, significantly underbuilt. September 2011, he goes to Boston Children's Hospital, and after a significant workup over there, he is started on etanercept, but without a diagnosis. Nobody knows what's wrong with him, but they start him on etanercept. He comes back, and his weight and height jump up. He stays very well. In those days, etanercept costs about maybe 30, 40,000 or maybe even more per month. Father is well-to-do, but up to a point. He starts reducing his dose of etanercept to the point when he gets symptoms. So every 20 days he takes etanercept, and that's the way he pulls on life till 2019. Am I being able to build up the suspense? Good. Fast forward to 2019, he completes a BSc in finance, applies for a job. When he goes for his pre-employment medical check, his blood pressure is 180 by 120. Okay. So, at that moment, I get an MR angio done, imaging done of his kidneys, and look at that very significant renal artery stenosis. Just a few days prior to that, I have the people who are the absolute champions of autoinflammatory disease visit SRCC. And a few years prior to that, I had sent them a sample of his blood with consent to further decode. That sample went in 2011. I didn't get the report till 2019. I made sure that this patient was seen by these doctors, Yvonne and Dan. When they came to SRCC, they get fascinated by this. They go back. And in April, I get an email on the same day that I get the MRI report that this child is homozygous for a disease called DADA2, deficiency of adenosine deaminase 2. So this is the problem. Now let's go forward. Why am I showing you this case? Between 2006 and 11, when I was seeing this patient, the disease was not described. Okay? This gene was first described in 2014, and hypertension has been reported as a phenotype, and renal artery stenosis has been seen in 4% of cases. So this was the first case report from India. as soon as we got the reports, and we published it obviously with some degree of pride. Very soon thereafter, maybe a few weeks or months, Dr. Lokeshwar sends me a case. This child is hospitalized at Leelavati, and everybody who's neurology in this room, please note, this child had been diagnosed as pure red cell aplasia. On tapering prednisolone, he gets fever, acute squint, and hemiparesis. CT brain shows small areas of infarct and focal calcification in the basal ganglia. MRI brain also shows lesions in the basal ganglia. By now, we start thinking our mind, because we've in the meantime read everything about DADA2 and recognize that there is a hematologic version to this disease. Therefore, we quickly send the gene studies, and it comes back quickly. This is a consanguineous marriage. Incidentally, an interesting story. This family lives in a closed compound in Nasik, and there are 100 family members. If you sit with their family tree, then you will understand why Rajesh told you about premarital counseling. They have played a league match with each other, one to the other, to the other, to the other. So it's that sort of complex story. Now, literally, while this patient is in room number 6 at SRCC, in room number 7 on the very same day, sir, this is the previous kid. You see the livido rash and you see the lesion in the brain over there. Literally that same day, I have been following up this child who was referred by an adult rheumatologist from Hyderabad. He's been coming to me from 2012. And recurrent ischemic strokes, headaches, seizures, squint, ptosis. There's a very, very senior mentor of mine. He still visits India every year. I've called him to Jaslok, showed him the patient, and what's happened? No, that's okay. I just want this to change the slide. And don't worry about my tremor. It doesn't worry me anymore. So, livido, recurrent ischemic strokes, MRI of the brain again shows issues. His MR angio is normal. But now, in 2019, when this patient comes, I say, hey, this guy has DADA2. We send his samples. Surely it comes positive. And these are some more images. So for us, by now it was pretty clear what the mind or the world did not know, we could not seek. Early diagnosis and management is essential. We haven't lost a single case. We now have 11 patients. Okay. Approximately 8% would otherwise die before the age of 30. Treatment is available and is progressively affordable. That is the key point. Now, this disease is very peculiar. It can present to any of you in this room, any of you. And therefore, I gave it the title, Common Beginnings with an Uncommon Ending. So let's see how that works. This patient, Dr. Suhas Kulkarni from Thane will remember. Patient comes with acute sudden onset blindness. I diagnose him as a case of polyarthritis nodosa. X years later, the child is in remission. His ESR always remains 55. He goes away to France to study. After I've known this disease as a hereditary form of polyarthritis, when he comes back, I tell him, please do your mutation studies. It comes positive. Okay? So now, he's taken his etanercept from Bombay. He takes it over there. I've given him an introduction to an adult rheumatologist in France. This came to an interventional radiologist and a urologist. Perirenal hematoma, renal artery aneurysm, ruptured gastric artery aneurysm, and a foot drop. So the foot drop was the peripheral neuropathy, which, the neurologists in this audience would definitely identify as a situation of peripheral neuritis. So this is the mononeuritis multiplex component of it. And then I have this patient with a libido and a generalized symmetric deforming arthropathy with abdominal pain. This child in her early days had a severe anemia which required blood transfusion. And this is a child who had the skin manifestations but had a necrotizing granulomatous adenitis in the lung. Everybody would say this is TB. This patient I owe to Dr. V.N. Tibriwala. So again, please note, this could be a TB mimic. So the clinical manifestations, as you can see in our series of patients, you have the vasculopathy and inflammation type, you have the bone marrow failure type, and then you have the immunodeficiency type. So there are three broad phenotypes that you may see. It's caused by biallelic pathogenic variants in the ADA2. It's located on chromosome 22q, first described, as I told you, 2014, and now there are about 400 cases published globally. What does ADA do? It stabilizes the vascular lining and monocyte macrophage differentiation. If it's not there, there is a lot of pro-inflammatory release of IL-1 and IL-6 and TNF-alpha. So look at it again to summarize. You have three circles: inflammatory and or vasculitic, hematologic or immunodeficient, but they can all meet and cross with each other. And then the most dangerous one, the pre-symptomatic. So you have one brother who you have diagnosed, the other brother or sister is quiet as yet and who may evolve later. And again, just to summarize the three types, and I'm going to take 30 seconds off for you to be able to just assimilate this. People like hematologists here, Mamta Manglani, Bharat Agarwal, will please assimilate the hematologic and the immunodeficient version. People like Dr. Vrajesh Udani, the other neurologist, please look at the CNS manifestations, and I'll take 2 seconds off to show you what the manifestations can be relevant to their specialty. Now comes the key issue. How do you test for DADA2? There is an enzyme test and there is a gene test. Do not be mistaken that if you have paid 20,000 rupees, you are wiser. Actually speaking, ADA enzyme testing trumps gene testing. Of course, if gene testing is positive, it helps you to corroborate your story, but a negative enzyme testing pretty much rules out the diagnosis. A negative gene test does not, because if you have a large deletion, duplication, or some intronic variants, you may come out with the patient being heterozygote. Please then confirm with ADA, and if the ADA is low, you can pretty much know that even if the patient is a heterozygote, he could still be having the disease. The beauty. Once upon a time, this drug would cost about ₹1,00,000 a month. Today, in approximately maybe 15, max 20,000, I know that it's not a small digit by any chance, but at least the middle class, you are able to offer them this treatment and say this is what exists. We have found very interesting ways of being able to break the ampule and do strange things with the ampule and inject the drug from behind the other syringe, etc., so that you can make the drug go a longer mild, but so be it. And you have etanercept as the originator molecule as well as the biosimilar molecule, while the other drug, adalimumab in India, is available only as the biosimilar molecule. Of course, you have to keep looking at the vascular parameters and the blood counts, ESR, etc., to make sure that everything is good. Would you give aspirin or warfarin to these children? The answer is no. It is believed that you might increase the risk of hemorrhage. So, we do not traditionally use aspirin. In whom would you consider a bone marrow transplant? Well, in my series, my patients with hematologic manifestations have fortunately responded to etanercept. I have not even needed to push them up to adalimumab, but those are the patients in whom you may require a bone marrow transplant, but the court is, let's say the jury is not yet out, you got to be a little cautious and you need a full 10-on-10 matched donor. Additionally, prophylactic antimicrobials, recurrent infections may require IVIG. IVIG is only for recurrent infection. It does not help the primary disease. And obviously inactivated vaccines and the usual influenza and COVID vaccines. What do you do about the pre-symptomatic SIB? Okay, and this has been a dilemma for me because you diagnose one child, they test the other child, and one parent said to me, "Sir, let's not test because if we get to know, it will simply create trouble." You can't do that. One day you'll have a stroke and that will be the end of the story. So there is no hard evidence, but the general consensus amongst pediatric rheumatologists is that you will please treat the pre-symptomatic SIB also. Now, out of my 11 cases, 4 belong to the endogamous Agarwal community. Okay. Similarly, Dr. Aman Sharma from PGI Chandigarh, he has another large bunch of adult cases, and he too has shown a total increase in Agarwals. Now you'll say, why Agarwals? What Vrajesh spoke about was consanguinity. What I would like to add to Vrajesh's talk is endogamy. They may not marry their first cousins, but a Bansal marrying a Goyal, a Jain marrying a Bansal, and Agarwal marrying a Bansal. They all basically, I don't know what they call it, but that Gotra or whatever, I mean, you can talk about these things because I am a marriage completely to a different community, as did both my kids. So I can't focus on this, but please look at this. Aryo Agarwal community is relevant. And therefore, 13 of the 18 North India patients and 5 of the West India patients belong to the Agarwal Jain community. In summary, consanguinity, endogamy, Agarwal community, multi-specialty myriad manifestations, ADA2 conformation genetic, TNF blockade, stem cell transplant, that's your story. A new disease that spans all specialties and all ages, Agarwals beware. So a couple of years ago, during COVID, there is a very close friend of mine in Boston Children's Hospital, and he has led this initiative on creating a consensus guideline where there were 35 people from 18 countries, and we got together, and this had been published recently. It's available easily on the net. So exactly 20 years have passed when on this very stage, we described Kawasaki disease, a medium vessel vasculitis, which is believed to be acquired. We don't know as yet. In 20 years now, we have another medium vessel vasculitis, but this time hereditary. I showed you some important events that happened in 2003, and now in 2023, these are some other important events that are happening. Is it time, Upendra, for a DADA 2 registry? And we could lead the way over here. Dr. Puili has become a close friend. Every time I go to Boston, I must have tea with him. This is my SRCC rheumatology team. Additionally, Pallavi is currently training in autoinflammatory diseases in Maryland at NIH. Dr. Divya Ramdas is at DY Patil, has already started there. And I'm pretty sure that at least 3 out of these 5 will continue to work at SRCC as I do a steroid taper. Thank you very much.
Do we have any questions?
Great talk, Raju. Yeah, I had a question and a comment. One was that the Agrawal community, we have seen 4 diseases now. One is MLC with subcortical cysts, which we described with Dr. Singhal in 2000 and something. We have another condition which I described called PCAN, which was also called Haloverden spots earlier. And the third one is calpainopathy, which is a muscle disease described by Dr. Khadilkar. I think your point is very well taken. You added one more, the other 2, and I think, frankly speaking, there should be some sort of method of getting the specialists together to see how many genes are common in the Agrawal community. And the reason why you said about the Gotras, they all started 3,500 years ago with Agra Sen, who was an emperor, and he said that everybody has to have 17 Gotras, and none of the Gotras should marry each other. But the problem is that he had bad genes, and that's the problem which has happened. The second question I had is, how many of your patients with strokes, how many did you have?
Totally, DADA 2 is 11.
No, strokes, with strokes.
Strokes are 3 or 4, not more.
Do you have any vessel calcification? Because one of your patients did.
Right. So the calcification in the basal ganglia is linked to the fact that this is being looked at as an interferonopathy. Okay. And basal ganglia calcification is something that is quite, and right now actually what Puili is doing, how I function is that I send him the blood sample on Friday by the courier in the evening. He received the sample on Monday morning. On Monday evening, I have an email saying present or absent. But when I send him the sample, I send the sample with one of my colleagues' blood sample. That acts as a travel control, as we call it.
Yeah. So the question I had is, we see this, it's very common in India, patients with basal ganglia strokes, usually in infants, in fact I think very unlikely after 3 years, who have basal ganglia calcification, which is along the vessels. Right. The MR angio is normal, and this is a small vessel disease, and the reason for this is not yet found. I'm just wondering from when I was listening to your lecture, whether there are some sort of heterozygous, sometimes you may have
have you
manifest heterozygote.
Have you tested
No, I haven't.
No, I'll tell you why. There's an entity called Aicardi-Gouttier syndrome.
No, that is fine.
That has been
Aicardi-Gouttier
done.
syndrome has different connotations of developmental delay and all. they don't get strokes. So this is a problematic, is we're not sure, and they get anemia sometimes, and they are very often anemic, but they're not red cell aplasia, they're basically iron deficiency. So the question was whether we should do this, you know.
No, what I would
genetic
definitely
studies in
tell you, as in when next time, let me get the ADA2 levels and the interferon levels tested.
I'll do that.
Yeah.
Thank you very much.
No, while the next question comes, let me tell you a joke. My son-in-law happens to be an Agarwal.
I'm
Okay?
a little worried because we have 3 Agarwal families in our building. So should I alert them? Yeah, it's a very common.
Don't open a can of worms. If they are happily, if they are happily married, let them stay that way.
No, they are not yet married. They have children, no?
No, but do they have any disease, any problem?
No, I have to find out. I mean,
No,
I can't ask them. Do they have
I
any
tell you
disease?
what, I'm not.
No. So let me go back because my son-in-law is an Agarwal. So when they did some pre-conception testing, he had 4 or 5 genes that you mentioned, while my daughter was clear. So she told him, that you're such a mess that I have come to save your lineage.
No, so on a serious note, you should offer all Agrawals at least 5, now the 5th one, the other 2 genes. There's something, one more, HMO co-lysase or something, some hematological disease. So there are 5 or 6 genes, and you should do it in Agrawal families, either pre-marriage, so pre-conception, or you could do it if they're pregnant, or before pregnancy, pre-conception.
That's something. Sir. Someone is taking a talk. Sir, can I make a comment?
Please.
Sir Shruti here. Lovely talk.
Yes, Shruti.
I think the discussion would be incomplete and the message taken home would be partly wrong if we understand that endogamy is affecting only the Agarwal community. There was a huge paper published in 2017 Nature which said that Southeast Asia, along with India, Pakistan, Sri Lanka, we are sitting ducks. So it's Vaishya community, Patidar, Patels, Mehtas, Agarwals, and a lot of us where a lot of these diseases are found to be common. And if we are talking in terms of Rajesh's take-homes, it's not just consanguinity, in general endogamy, which should, or highly inbreeding, should be kind of avoided. And if we look at these population-based disease-specific profiles, it will really help us to move ahead in a more positive
what
manner.
Shruti is saying is very true, and I'm not here to only single in on the Agarwals. And actually, I know the paper you're referring to, there is actually a write-up in the New York Times, which there's a photograph which says, boiling pot of genetic disease. Is that the one you're referring to? So there are Vyasas, Patidars, etc. But this particular, there's a founder mutation that has come down. The other guys may have certain other diseases also.
Sir, one question related to Kawasaki disease. You mentioned about the medium vessel disease because of the DADA2.
Correct.
A child who is proven to be a Kawasaki, who is IVIG resistant, gets better with the infliximab, comes with a recurrence of a Kawasaki disease at a young age of around 13 to 18 months. Any role of a DADA2 mutation and a Kawasaki disease correlation?
I would definitely think about doing a ADA2 in this child. Definitely think about it. I would ask for a history of consanguinity. But right now, off the top of my hat, I cannot straight away tell you, but I would go back and look and probably call you up as to how many DADA2s have had coronary artery involvement. Correct? So if your patient did have coronary artery involvement, that may either be a deal breaker or a deal maker. Get me? So, but it's an important question that I will go back and ponder upon.
Thank you, sir.
Thank you, everyone.
Thank you
Thank you,
so
sir,
much.
for
Thank
such
you
an
so
excellent
much.
presentation. So after pediatric rheumatology, now we move on to pediatric surgery. Our next session is titled Expose to avoid going red in the face. For this session, we have expert Dr. Khan Shah. Sir is a pediatric surgeon working at Borivali Healthcare, Nanavati Max and Jaslok Hospitals. And to moderate the session, we have Dr. Jagruti Sanghvi. She is a consultant pediatrician at Nurture and Suture, Surgical and Pediatric Clinic, Mumbai, as well as at Nanavati Max Super Specialty Hospital and Advanced Multi Specialty Hospital. So I welcome the expert and the moderator on the dais, please.
No, I think this
Can I have a pointer?
Yeah, you can.
Thank you. It doesn't work on the LED, I think.
Sorry.
This is for you.
Good afternoon, everyone. Two of our EB members are Agrawals, so I think Sir has scared the two of them quite a bit now. Coming to our topic, it's called Expose. A lot of us, like I have been interacting with people during the tea break, and I realized that they have such massive practice that sometimes it's difficult in our busy practices to expose a child, especially the external genitalia. But there could be a variety of serious conditions that we can uncover if we actually bother to uncover a child. So after an informed verbal consent from the parent and if possible from the child, one needs to have a gentle but complete exposure of the external genitalia and also explain the child that it is not going to hurt the child in any way. So we are going to basically uncover a series of genitourinary external conditions which can have serious implications. Coming to our first case, a 5-year-old girl presented with this firm lump in the groin, which was noticed 6 months back. The swelling was initially visible sometimes, but since 1 week, it has become persistent and sometimes painful. My question to the audience is, what is the likely diagnosis? Inguinal lymph node, inguinal hernia, obstructed inguinal hernia with bowel, or an obstructed inguinal hernia with ovary. So have your voting pads ready, and your voting starts now. Could we have the results? Okay. So we have a divided audience over two, that is inguinal hernia and obstructed inguinal hernia with ovary. Can somebody who has voted for 4, anybody can raise a hand and say, why do you think this is so? Anyone? Okay, we go over to our expert. Dr. Kant, can you tell us why do you think this is an obstructed inguinal hernia with the ovary?
Yeah, thanks. So typically, if we see the history, there is a lump which is coming in and out. So hernia is not a question, that is a hernia. In the last 1 week, it has now become a little painful and it's there all the time. So we are now thinking of obstruction. But in an obstructed hernia, if it was bowel, the child would probably present a bit early, probably within a day or two, and would be in much more pain, and it would not be like an indolent looking swelling like what you saw. An obstructed bowel will start getting red or bluish very quickly, and the child will probably start vomiting. So this is more like a very typical obstructed ovary. I would also like to say that in girls, typically obstruction, if there is an obstructed hernia, more often than not, it's an ovary. Bowel getting obstructed in a girl is a very rare thing. And you will usually feel a very lumpy oval feeling in the groin, which may be slightly tender but moves around freely. And that is usually the ovary which has come as a sliding hernia and get obstructed because it's too big to go back in. And it's sort of, if you see this arrow, I have shown the direction. So the ovary comes out through the external ring and then goes this way, and then it can't go back.
So what next would you like to do here, sir?
So yeah, if you can just go. So if you're in doubt and then this child has not presented very acutely, you could get an ultrasound abdo-pelvis done. It'll help you in two ways. Every child, every female child, we also want to rule out something called complete androgen insensitivity, because you could actually miss that and there would be no other sign except for ruling it out. So you'll have to look for Mullerian structures in every female child with a hernia. All India Institute actually does karyotyping for all of them, but in clinical practice we don't do that. But we definitely do an abdo-pelvis to check for Mullerian structures, and then we would also be able to see that this is an ovary and not a bowel.
So if there are Mullerian structures present, then you would not need to do a karyotype, right?
Yes, absolutely. So yeah, I mean, this would be an urgent surgical referral. It's an ovary stuck. It could get decompromised. Usually the ovary doesn't get, like the bowel, it doesn't start losing blood supply so quickly. So, but it's still an urgent surgical referral and you would still need to explore this child. Very rarely we have to do a laparotomy for a female child. For a male child, sometimes if the bowel is compromised, then we may have to. But for a female child, usually laparotomy is not required. A simple hernia surgery is enough.
So suppose you had a similar case in a male child. So which of the following is false for an obstructed inguinal hernia in a male child? Please have your voting pads on. One is ultrasound is useful for diagnosis. There is a high risk for testicular atrophy. Obstruction occurs in about 5% of infants with hernia, and it can be safely reduced under sedation and analgesia. Which of the following is false? Audience, voting poll, please. Can we have the results? Okay. So most of the audience here feels that it can be safely reduced under sedation and analgesia. There's a very small...
It's the false.
Sorry, is the false
Cannot
statement.
Be. So
it cannot be safely
reduced.
Yeah, sorry. So there is a small percentage which has mentioned 3. That is the wrong statement, that it is obstruction occurs in 5% of infants with hernia. Anybody who has mentioned that, can you just come up with more clarity on that? Is it more or is it less? Yeah, that's probably what Dr. Kant wants to highlight to us. So can we have the slide, please? Yeah, Dr. Kant, can you highlight on this aspect? The reason why we want you to highlight on this is a lot of times inguinal hernia, when they come to us in practice, the parents want to delay the surgery, the surgical part of it. They want to feel that let the child grow a little older. The child is just 6 months old or 9 months old. So one is, can you tell us what is the right age when we must try to deal with a inguinal hernia? And what could be the complications thereof if we don't treat it at the right time? And whether obstruction is that common or not?
Thank you. So yeah, it was very interesting that people feel that it cannot be safely reduced under sedation and analgesia. So we'll go one by one. So ultrasound is definitely very useful. In fact, I've been caught out once that between our pediatric intensivist and Nanavati and I, we were arguing whether this is obstructed hernia or not. He felt it was, and I felt it wasn't. So we said, okay, obviously let's do an ultrasound, and it was clearly an obstructed hernia. So if you're in doubt, especially in premature babies, where you cannot feel very conclusively, the bowel and hydrocele might feel very similar in a very small premature baby. So, and even otherwise. So if you're in doubt, you can always get an ultrasound done. It will clearly show that this is bowel and whether it is compromised or not in vascularity, and hence it will be useful. So you can definitely get an ultrasound done. Now coming to obstruction. So obstruction is actually very common. It's not uncommon in clinical practice. Overall, it's 10 to 15% or 12 to 17%. Transillumination doesn't work. So any bowel of a child will transilluminate. So that's not a test that you can differentiate between hydrocele and obstructed hernia. But we have to remember that if you look at this graph, at 1 to 2 months of age, the risk of obstruction is almost 30%. So 1 in 3 or 1 in 3.5 children will actually get an obstruction. This is how common it is. We need to pick up the soft signs. What are the soft signs? So when there is a canal and the bowel is getting obstructed in the canal, we have to remember that the testis ka blood supply, the vessels are also going in the same canal. So the first thing you will get is some testicular edema. So even if the child has come with history of painful crying last night, and today you don't see anything, just feel the testis. If the testis looks swollen, and if there is a known history of hernia or there was a known groin swelling, then you would think that this is a hernia which has probably got obstructed and unobstructed on its own, and that's why there is testicular swelling. And if this persists, and if the obstruction was not relieved immediately, we have a very high risk of testicular atrophy. Almost always, the hernia can be reduced very safely with a little bit of sedation or analgesia. The first thing to do would be to admit the baby, keep nil by mouth, and give good analgesia. Even simple IV paracetamol is good enough. If you have the facility to give a little bit of fentanyl, that works very well. And then sedation, rarely if you need, but I use sedation if I've got to reduce it. So I use fentanyl or morphine so that I can give both sedation and analgesia at the same time and reduce it. So it can be reduced very safely. It prevents the super emergency of having to look for strangulation and then operating as a laparotomy. See, strangulation is a laparotomy. So obstructive hernia can be reduced safely. Then what we do is we wait for 48 hours for all the edema to go down, because as I said, the vas and vessels are just there. So the sac will be very friable, and vas and vessels will also be friable. So we don't want to damage any of them. So wait for 48 hours, keep the child admitted, and then operate after 48 hours to do the herniotomy.
Okay, so important take home here is that there is maximum chances of obstruction in the first 1 or 2 years of life. So one should not wait, but go ahead with operative intervention.
Yeah, sorry, just to answer your question, when should a hernia be operated?
Yes.
Textbook of pediatric surgery, it's within a week. So once you diagnose a hernia, you have to explain to the parents that there is no non-surgical treatment.
Way of treating it, yeah.
And if you wait, then you're going for all this. So there is just no point waiting.
Is there any age criteria, or sorry, any weight criteria?
No, not at all. Not at all. The only hindrance to operating within a week is those extreme premature babies, where we say we'll operate near discharge from the hospital. But that's about it. Other than that, every other child needs to have a hernia surgery as soon as you can, usually within a week or two, and not delay that.
Okay. So we move on to the next case. It's a 10-year-old boy with pain in the scrotum since the past 2 days. The pain worsened on the day of presentation. He had difficulty in walking. There was reddish scrotum on the left side with swollen tender testis. The other testis was normal, and the urine routine was also normal. This was the presentation with which this child, 10-year-old, came to us. What, audience, is the next best approach? Can we have the voting ready? 1 is ultrasound scrotum, 2 is immediate ultrasound with Doppler, try analgesia, ice applications and antibiotics, and immediate pediatric surgical referral. Can we have the voting on? The results? Yeah. So here we have almost 70% people feeling that we must do an immediate ultrasound with a Doppler of the scrotum. So can we have the next slides, please? Yeah. So there can be 2 good answers in a single question. So immediate ultrasound with Doppler of the scrotum and immediate surgical referral. Both are important or correct answers here, and Dr. Kant will tell us why. Yeah, you can talk about what do we see on.
Yeah, we'll go through this in a little bit more detail in the coming slides. But what I want to say here is that this is an emergency. It should be treated like an emergency. Whether you do an Doppler or whether you speak to a surgeon or whether you do both, you have to call the radiologist, you have to call the surgeon, and not just write a chitti and refer, because that's not the way to refer a acute scrotum. So whichever way you follow, either you call the radiologist or you call the surgeon. But that's, and we'll talk about it in a little more detail further.
Yeah, so it's important for the parents to know that this is a real emergency. So before that, I'll show you a couple of similar cases which can come into our practice. An 8-year-old boy with severe pain in the scrotum plays football in a school for a club, and he also comes with a high-riding swollen tender testis. Another case can be seen in a 3-year-old child with pain and swelling in the scrotum. This is a picture we've got from Dr. Pankaj Shroff. For the past 2 hours, just a history of 2 hours with no history of injury. what is similar in these patients is that they have all come with an acute scrotum. The first case was over 2 days, whereas this was a small child with just 2 hours. So can you just tell us what are we actually looking at from a DD perspective and how important it is from the perspective of the question that we asked, immediate surgical referral or doing an ultrasound? Why are those two answers almost similar?
So before we go that, I just want to show you 2 or 3 slides. The first is what is actually torsion. And I just want you to see a video and then you'll appreciate it a little better. So this is us operating on that second child that you saw. The scrotum was not very red, but high riding testis. High riding testis and very tender short history. So if you see the testis is blue, and the epididymis is quite blue, and there are about 2 turns. Usually the commonest is 2 to 3 or 4 turns. It's never 1 turn. And then you can see immediately the epididymis already started pinking up. The testis takes a little more time to pink up, but it does pink up. If you can just go to the next slide.
Yeah.
Here you can see the same child now. This is almost pinked up and there is some pinking up of the testis. But here we can imagine that the blood flow has re-established. It was a short history. We caught it in time. So this is why this is so gratifying. This is why we should not delay these children. And that's why we are here to talk about this.
So
Now, this is a condition that gets mentioned often, but you may not have seen a photo of this. That's why I put it here. This is a torsion of the appendage or appendix of testis or epididymitis of, appendix testis.
Appendix testis.
So so this is actually pretty common and gets missed also. So
again, there is an interaction that I want you all to do.
before I come to the actual role of ultrasound, we'll just go through this now.
Okay. Which of the following is false regarding acute scrotum? Please have your voting pads ready. Epididymo-orchitis is the commonest cause of acute scrotum. Testis can survive less than 4 to 6 hours after torsion. Torsion of appendix testis, the last case that Dr. Kant mentioned, is commonest between 2 to 8 years. Testicular torsion can occur at any age from neonate to adolescence and probably longer. Acute scrotum must be explored if your diagnosis is in doubt.
False answer.
Well, yeah, let us know what is false. The answers? I think we have a good audience.
Split house, but yeah,
Yeah,
correct.
almost, yeah. So I think we'll not waste much time over the
Actual answers,
graph. You can just discuss a little more about this.
So let me just mention that testicular torsion can actually occur at any age. There is something called an entity called neonatal torsion where there is a peak incidence, then a little less incidence, but we've got 6-month-olds, 5-month-old, 2-year-olds, 3-year-olds, every single age group we've got children who have had torsion. Acute scrotum, they will come to this. And torsion of the appendix testis is actually the commonest cause between 2 to 8 years in very, very large studies worldwide. This often gets reported as there is a catastrophic event in the scrotum. You get inflammation everywhere, and it gets reported as epididymo-orchitis, but it's actually not the commonest cause. It's actually the torsion of the appendix, which is the commonest cause, and epididymo-orchitis actually it's not really common. So you really need a reason for epididymo-orchitis. Epididymo-orchitis just doesn't happen like that. So either you need a parvoviral infection or you need a reflux disease or mumps. So you need something for it there to be epididymo-orchitis. So it gets reported like that is usually this. So
Yeah,
we'll
but
go
the
to
way I think forward
But the crux is when do you do ultrasound and what to do. So yeah, I think we'll have to just keep, yeah. So we have to understand that ultrasound can only pick up some testicular torsions and not all of them. So it's only 86% sensitive. What we are looking on ultrasound is that there should be normal intratesticular perfusion. Now what has happened with the new age ultrasounds, they are so good, they'll pick up some small flow in the epididymis or in the testis. And that usually we think that it is not torsion. So the fact that we are able to save the testis means that it is not a complete cutoff of blood supply, which means that there is always some flow, which the newer ultrasounds are picking up. That's why this big study is very important, where they have said that actually the efficiency of ultrasound has made it such that now it can only sensitive only for 63%, because actually it's over-diagnosing or under-diagnosing because of the better equipment. And again, there is something called intermittent torsion. So we've always had children who had like a 24-hour history, not like a very short history. This graph is very important. At 24 hours, if there is torsion, you lose 80% of the testes. At 0 to 6 hours, you lose only 5%. So whatever you do, whether you do an ultrasound or you do a reference to a surgeon, it has to be done in this window. This is the only window you have, 0 to 6 hours of onset of symptoms. So it doesn't matter whether you have an ultrasonologist or whether you have a surgeon, you could have this. Everyone's practice is slightly different.
Suppose there is no access to an urgent ultrasound with a Doppler. Is it a good idea to just go for an exploration?
Yeah.
What if you get a negative exploration?
So that's a really good question. So when finding support or raise, this is from these last studies, suspicion for somatic cord torsion, emergency exploration is the only way forward, because you want to save these testes. The negative exploration rate is not more than 15 to 20% at most.
Okay.
So it's really not that high, and we would rather save those 80-90% testes than worry about those 10%, 20% negative explorations. We always counsel the patients that this might happen. And when I say negative explorations, you will still have those appendicular torsions and all those also. So those will also get relieved. So that's why exploration, if in doubt, is a better option. If you have very good ultrasound, so we'll come to the next slide now.
Yeah. So what to look for in ultrasound, as you
Yeah.
rightly said, is a proper perfusion, not just little bit of flow going in, right?
So some flow is not good. You need normal testicular flow. If your ultrasoundist tells you concretely, that's why it's a phone call and not a prescription and a report. If they say conclusively, concretely, this is a normal testicular flow, then please, you can actually, even the appendix testis does not need exploration. You can just manage with simple analgesia. But they have to be very sure that the testis is safe. If they can't tell you that, then ultrasound is not enough.
Okay, we all know that we need to explore and fix the other side, because the bell clapper deformity could be there on both the sides. So we'll go a little further, a little faster. A follow-up Doppler, especially in a case which has undergone a torsion, as you had discussed, would be a good idea, so that the parents are relieved that there is not going to be any further torsion after we have fixed the testis. So maybe we can go to the next case. Not very common, but when these patients come to us, it baffles us as pediatrician. So 10-month-old male child with deflection of urinary flow, with bending of the penis while passing urine, and a hooded foreskin. We all know that we are dealing with, there's a hole which is not at the right place. So this is a case of hypospadias. So in a child with hypospadias, which of the following is false? Position of the meatus, please have your voting pads ready. Position of the meatus determining the number of stages of surgery. Caudy surgery is done in the first, correction is done in the first surgery. Circumcision is contraindicated, or a fistula rate is 10 to 15% for most types of surgeries done for these patients.
It's a false question. So
Yeah, please
which one is the false?
mention which is the false statement. Yeah, the answers, please. So here is the catch, because we don't see too much of hypospadias. And here, the textbook teaching that we have had over the years, in fact, I was also baffled when I was discussing this with Dr. Khan. So we will let him answer the correct question, the correct answer. The false statement here is?
So the position of the meatus actually means very little when we correct hypospadias. It actually has almost no connotation on how many stages or what type of surgery, etc., etc. Caudy is a bend in the penis, so it has to be corrected in the first stage, because if you don't correct the caudy and you've done the hypospadias repair, and then there is a caudy, and then you need to do something about it, then you'll have to undo the whole repair. So caudy correction happens in the first stage. So every child who has a bent penis, you have to worry that they might always need 2 stages rather than 1 stage, because the first stage will be a caudy correction, and second stage with a graft, and then second stage maybe a urethroplasty. Circumcision is absolutely contraindicated, and even when you do religious circumcisions, there is a very high incidence in certain populations of having a hidden hypospadias. So again, counsel the patients for even religious circumcision that you may find it. And at the time of circumcision, if you find a small hypospadias, then circumcision is contraindicated.
That's because it's also used, the skin is...
we use that skin to actually do a lot of our repairs. And that's a very precious skin. That is a very thin skin. It is not keratinized. It is transparent. It doesn't bear hair. And you don't actually have any other skin like that. So we use that skin.
Okay. So can you just tell us a little bit about the basics of what we go for the surgery? Yes.
Yeah. So I just wanted to highlight that it's a complete failure of ventral tissues. This urethral plate is very thin. It may look like it's a okay job to do, but this is a very bad urethral plate, and I don't have material to do a surgery. That's why that position of meatus actually doesn't mean anything. What material I have, there is no hooded foreskin here. So actually I have almost no material to construct this urethra. So this is a very difficult surgery. It may look innocuous, that's the only thing. So while counseling, please be aware that the position of the meatus is absolutely not really a point of counseling at all.
So can you just tell us a little bit about basics of the surgery for hypospadias, the timing, what are the complications that as pediatricians, if patients come and ask us, we could ask them to look for or to expect rather?
Yeah. So now,
yes.
So, yeah, I think we got only 1 or 2 slides. So surgery, we start at 6 to 9 months because before toilet training, we want to finish all the stages and whatever complications may arise from the surgery. We already talked about stage surgery. We must rule out disorder of sexual differentiation. If you have undescended testes with hypospadias, please be careful. Don't recommend surgery. Just send it to an expert who's expert in DSD or a pediatric surgeon who deals with DSD, and don't recommend surgery at all.
Especially proximal cases.
Yeah, any hypospadias with undescended testes, don't recommend surgery at all because we don't know at that point what we are dealing with. And 10 to 15% fistula rate and stricture rate is very common. You may see patients much later, 2-3 years after, and they may have some difficulty in passing urine or infections. And then please do refer back because they may have a stricture. That's all.
Okay, thank you. Now these are going to be 3 cases which are rapid fire, and because of shortage of time, maybe we will not go through the voting poll and we will direct those questions to you. 2-year-old male child with incidentally diagnosed left-sided non-palpable testis not felt in the groin. Which of the following is false? And don't put the voting pads because we are short of time. Retractile testis should be monitored 6 monthly. USG not confirmatory for abdominal testis. Cosmetic testicular implant may require revision surgery, and surgical correction of UDT is not advised before 9 to. Just a couple of lines on each one of them.
Can you go to the next slide, please?
Yes.
Yeah. So retractile testis may ascend at 4 to 6 years of age and hence needs to be followed up, whether you do it 6 monthly, annually, but parents need to know that. Ultrasound and MRI are only 90 to 95% sensitive and may miss out on testis, so they cannot actually guide the treatment. We can put a testicular implant, but usually counsel them for later age because otherwise you have to keep putting a bigger one as the child grows.
What is the best age for?
Puberty or post-puberty. As long as the child is not getting mentally harassed by not having one testis, usually there is no urgency. If the child says at 8, 9, 10 years of age that there is something wrong with me, might as well go ahead and put an implant, a silicone implant. And an undescended testis will come down only up to 4 months of age. By 3 months, dysplastic changes have already started. There are very few studies to prove all this, but there are some big studies from Australia. So we follow that, and hence surgery is done at 6 months and no later than that. Very quickly, palpable is the one you can palpate. The one you can't palpate, you need to do a laparoscopy. That's it.
Okay, thanks. The next case, commonest, seen in our OPD practice, is 1-year-old male child with tight foreskin covering the external urethral meatus. In this child with phimosis, which of the following is false? Urgent circumcision required as high risk of UTI in boys with phimosis after 1 year of age. Pull it down forcibly and lubricate with massage oil daily. Local application of steroids for 6 weeks or leave it as it is.
Okay. So physiological phimosis is one which doesn't have scarring, can be left to at least 4, 5, 6 years of age without doing anything. If it is distressing or causing ballooning, gentle retractions, not forcible, but 1 millimeter retractions, rotational massages are good enough, and they will usually resolve the problem. So phimosis almost never causes UTI, very, very super rare. And steroids we usually
But
don't.
contrary, if there is a UTI and a phimosis, one must go ahead and do a circumcision.
I would rather investigate for the UTI than do the circumcision first. Because I would rather investigate for a reflux
VUR
disease and something else rather than do circumcision.
But suppose there was a VUR also, and there was also a phimosis, wouldn't you also operate for the phimosis?
No. So we've stopped doing circumcision for VURs and posterior urethral valves for last many years because that evidence is not strong. There's a lot of evidence in America that they have done retrospective studies, but it's really not a strong evidence. So we've actually stopped doing circumcision for any urological surgery completely now.
What about massage? A lot of ayabais seem to specialize in that.
Yeah.
Massaging.
So those are the ones who come to you at 1-2 years of age because in infancy, some IABI is forcibly retracted and now you have fine scars. So those are the ones where you can apply steroids little early, but I would still avoid before 3-4 years of age. Avoid steroids because once it opens up, then you have to clean it every day, otherwise it will close again. So try and avoid any intervention or do gentle rotational massages, let it open gently. And definitely don't aim to retract it completely before 5, 6, 7 years of age. Absolutely not required,
So
as
you
long as
could
the
just
child is
leave
passing
it.
urine.
You could just leave it as it is.
Leave it as it
and
is the best
steroid
option.
of choice?
Mometasone is what I use because most of them have already tried hydrocortisone or something else by the time they come to me.
Okay, last case. 11-month-old girl with incidentally found vaginal synechiae. Why? Because we all attended today's Embicon and we bothered to expose and have a look at this child. There are no symptoms altogether. Which of the following here is false? Surgery is commonly required. Steroid cream to be applied for 2 to 4 weeks. Estrogen cream or disorder of sexual differentiation may be present.
So surgery is almost never required because all we are going to do in surgery is just forcibly open it and it will close again. So surgery is never required. Steroid cream, not never, but I have not done it for many years, but it's really not required. You can go with either steroid or estrogen cream and there is nothing much to choose between them. Once it opens, please call them again and give them some non-steroid, simple oil-based cream because it needs to be applied for the next 3 months to keep it open. And avoid diapers because usually these 3-4-year-old children will come with diapers and then they'll get this. And recently I had a child where they were applying this cream for 1 year and actually it was a DSD because the way the pediatrician described to me on the phone, it was very clear that this is not a vaginal synechiae because labial synechiae rather, sorry. Because in disorder of sexual differentiation that it will not be like a thin membrane, it will be like skin. It is skin and it is a smaller introitus. So it is a DSD and it is not a labial synechiae. That is the only thing. Thank you.
Yeah, another thing I would like to add here is estrogen cream when we apply, there can be a lot of hyperpigmentation of the genitalia which parents get very worried about. So usually we would ask them to use a cotton bud or something to apply and tell them that this is going to be reversible once you have stopped applying the estrogen cream. So yes, and in doubt we can always call or send pictures to our pediatrics surgeon. A simple photo or a video, I'm sure you would be able to guide us further.
Thank you. Thank you very much. It has been absolute wonderful working with Dr. Jagruti. Thank you, Dr. Rajesh Chokhani, for inviting us, sir, and thank you all of you.
Thank you, everyone. Thank you so much.
So we move on to our next session now. Our next session is updates in tuberculosis. For the same, I would like to invite on stage Dr. Bela Verma, Madam. Madam is Professor and Head of Department of Pediatrics at Grand Medical College and JJ Hospitals.
Good afternoon, everyone. I stand between lunch and my talk, so please bear with me. I shall try to make it as brief as possible. I've already been given a very short time. So tuberculosis has been the scourge of mankind for many centuries now. But evidence of tuberculosis has been found in the spine of the pharaohs within the pyramids. So we know how many centuries it has been around. And secondly, there have been several attempts made in the last 3.5 decades to control the disease as well as eliminate it. But the bacterium proves to be smarter than us. And the recent COVID-19 pandemic has resulted in several collateral mini pandemics including a huge setback to the healthcare system, delayed vaccination schedules, and rise in tuberculosis cases, including drug-resistant tuberculosis among children as well as adults. And an update on TB coming up every year is testimonial to the fact that there are changing strategies for treatment, diagnostics, and also it says that the disease is becoming more and more difficult to control. And therefore, this small attempt to share with you all the updates in a very brief time. And I confess that I'm a learner like all of you all, and I'm not an expert, so kindly bear with me. What I am going to speak on is paradigm shift in the diagnostic criteria, changes in the definitions, some case discussions, algorithms, treatment categories and regimens of DSTB. I will not be touching DRTB today. A new DRTB module is being rolled out soon, and therefore you are going to have two modules, one for DSTB and one for DRTB. Follow-up and monitoring of these patients and TB preventive treatment. So let us start with case 1. This is a 6-year-old boy with fever, cough since 1 month and weight loss, has pallor and reduced air entry on the right side with occasional crepes. This is the CBC, HB is 9.2, 6,400 lymphocytes, and neutrophils are 35 and 50. What next? So this is an X-ray chest, very obvious that there's an opacity in the right hemithorax. What will we do? We'll try and tap it. So, and we further investigated. The TST was 15 mm, USG was moderate pleural effusion with consolidation. A tap was done. It was a straw-colored fluid with 450 cells, 95% lymphocytes, proteins of 4.8. Will you start ATT? Yes or no? You can answer on your, please answer on your voting pads. Surprising, ATT has to be started. This is a case of presumptive TB. Even though we have some evidence in form of TST of 15 mm, we can see that the pleural tap is suggestive. The X-ray is abnormal and suggestive of TB. So we start ATT, but you need to investigate this child further because the bottom line is microbiological diagnosis of all cases of TB being done upfront from the very first time the patient presents to you. And the way we write the diagnosis. So I am not teaching you updates separately. It is incorporated in my slides. You have to pick it up. So the diagnosis has to be given in detail as a right pleural effusion, which is GL NAT negative, MGIT negative. The pleural fluid is also NAT negative, MGIT negative, and the drugs that have been given are 2-HRZE plus 4-HRE on a fixed drug combination, and notification is done. This is the complete diagnosis that has to be written on the case paper. How many samples will you send? Can you have a voting pad, please? Excellent. So 2 samples have to be sent for any patient you have, whether it is a GL or any other tissue aspirate or biopsy. You have to send 2 samples on the very first time when you're investigating. One is for the CB NAT gene expert, and second is for culture, that is MGIT. If it comes positive, then a drug sensitivity testing has to be done immediately. So this is one of the paradigm shifts in the diagnosis, which is a recent update since last year. What is the role of TST or IGRA? They are only prognostic. Role of ESR and ADA, non-specific. ADA usually not done. It is for adults where you want to diagnose malignant effusion versus a TB effusion, whereas in a child we want to know whether it is a tuberculous effusion versus a bacterial effusion. Is culture mandatory for each patient? I need to know how much we are aware. So can you just take the voting pads? I have only 6 questions. 3 are done already. Yes, it is. It is mandatory to send culture. Please do not forget it. And that is a time when you may actually pick up. So gene expert may be negative, that TST may be negative. That does not rule out. An X-ray test may be non-specific and normal. So it does not rule out tuberculosis, and you must always and always send for culture. What is a presumptive TB case and what are the recent updates in the diagnosis? So we always have followed this symptom characterization for suspects, that there's a fever of 2 weeks, cough of 2 weeks. If you attended the asthma module, they will even describe the different types of cough they have: continuous, intermittent, remittent, etc. So knowing the history is extremely important, because the parents tend to usually overdiagnose by saying khasi roj aati hai or whatever. So you have to know. And of course, you have to document weight loss. For that, you have to have a series of weight charting on the growth chart, whether this child has lost significant weight or there is a failure to gain weight in the past 3 months in spite of good nutrition. As also we ask for history of TB contact in the family, a recent contact, which will help us in children because they usually have non-specific symptoms. And of course, please understand there is a pulmonary tuberculosis and there is an extrapulmonary tuberculosis where there is lymph node or a meningitis of insidious onset or a spine gibbous. So any non-specific symptom but in a contact with an infectious TB case has to be taken very carefully for a diagnosis of pediatric tuberculosis. So this is a patient of presumptive TB. Earlier we had classification as a suspect, a probable or a confirmed TB. Now that is not there. You have a presumptive TB. So this is a child again who has a symptoms with or without a contact with a pulmonary TB in the last 2 years. So the first case where we did not get anything much except in the pleural tap is a case of presumptive TB. How should we proceed now? So we know that the clinical symptoms keep on overlapping. Children have a very poor GL yield, so even though we attempt to get a GL aspirate for gene expert and culture, we may not really get a positive test. This used to be a conventional method that we have a history, we have a TST and we have an X-ray test done. Plus we used to do a ZN smear, which is outdated as of now. But what is important is your MGIT, and most of the cases in pediatrics are clinically diagnosed. But we still make an attempt, even if it has to be an invasive procedure to be done, we still have to make an attempt for an MGIT. Because the very first time, if you're able to diagnose a drug-resistant TB, you save precious time. Otherwise, you're giving that child treatment for 3 to 6 months and then deciding he has not improved, or rather he has deteriorated, and then you start investigating. So to cut short this important time, we do culture upfront. If we have a diagnosis of MGIT by microbiological diagnosis, then the DRTB treatment is started immediately. So the strategic shift has been that from a more efficient detection of MTB, better diagnostic methods, it has become detect the resistance to the key drugs, especially your first-line drugs. So universal DST used to be at least rifamycin sensitivity or resistance. Now it has changed to at least rifamycin resistance along with fluoroquinolones among all TB patients. What is available to us? We have got CBNAT, TrueNAT, line probe assays, and TB cultures. 2 samples to be sent always. I am bypassing all this because we can read this in the textbook, all these tests which are there. TrueNAT is an indigenous Indian company prepared test which is very easy to battery operate, and it is useful in the interiors and smaller setups. So culture is the gold standard for diagnosis as the liquid culture medium. And we do the phenotypic drug testing for all the drugs as well as for the non-tuberculous mycobacteria. The turnaround time is shortest for CBNAT, 2 hours, followed by first-line LPA, 72 hours. Liquid culture isolation and LPA drug testing 2 to 4 weeks, and liquid culture isolation, that is by 6 weeks. If any specimen is positive, then the disease is labeled as a microbiologically confirmed tuberculosis, and you must then seek for drug sensitivity. The sampling methods, children do not expectorate. So what we have to do is get a good gastric aspirate, either overnight fasting if the patient is admitted, or if the patient is brought fasting to the OPD, then we try and collect it by passing a orogastric tube. Other methods are induced sputum, where we give hypertonic normal saline and try to induce cough, but that has to be done in a very restricted area with proper mask being worn by the person who's doing it to protect themselves. Bronchoscopy and BAL are the invasive methods, but sometimes they are very, very useful, and if you have a setup which can help you, one must try to do a BAL or a bronchoscopy, especially for non-resolving pneumonias and a child who is coughing incessantly. So this is presumptive TB, and this is what the algorithm was, that you look at the chest, which we said it's highly suggestive, non-specific, or it is normal. So when it is suggestive, like a lymph node, we can see over here the mediastinal and the paratracheal nodes. Here it's a miliary TB or a fibrogravity TB. We know that is a highly suggestive TB. And therefore, we always follow the algorithm. This is available in the NTP module, so I am not going to go over it in detail, but the importance is, along with clinical symptoms of fever, cough, weight loss, in spite of poor nutrition, we do a TST if available, that is 2TU. We do an X-ray to see whether it's normal, highly suggestive, and we try for a specimen, which may be a GL, a lymph node biopsy, or a pleural aspirate, or ascitic aspirate, whatever you can get for culture and gene expert. That is not to be forgotten now. So this is an algorithm which is already available, and one can go through it, very simple. HIV is also done in all these patients, so I must stress on that. And all presumed cases, you must do CB-NAT. If it is detected, if it is not detected, it's a clinically diagnosed, and you will treat with a standard regime and follow up that child. If you can, if the MTB is detected, then you look for the RIFA resistance, like I told you, and if on a direct sample, the first line LPA can be done. So these are the details of what is a first line LPA and a second line LPA. Now this is second case. It's a child who is a poor eater, has recurrent abdominal pain, no documented fever. What would you do? He has some nodes on the sonography. So can I have a voting pad session, please? Yes, that's right. So for this patient, no investigations were done. This seemed like a case of functional abdominal pain because there was no red flag sign. So we have 4 forms of abdominal TB: intestinal, nodal, peritoneal, visceral. And if there are no organic causes seen, or whether there are no red flags, then you just have to keep this child under follow-up. So he has no red flag signs. Commonest are, this is the way they present: abdominal pain, fever, distension, weight loss, anorexia with hepatomegaly or ascites. So this would suggest that there is abdominal TB. If none of these are there, also the appearance of the lymph nodes on sonography is extremely important. The loss of concavity with central necrosis, short axis diameter more than 2 centimeters, all these are suggestive of TB. So if that is not there, then one should avoid starting ATT, and just isolated mesenteric lymph nodes have no meaning. So central necrosis, conglomerate lymph nodes, caked omentum, multiple microabscesses or SOL in the liver, spleen, loculated ascites, mesenteric thickening will increase the possibility of a tuberculous abdomen. What is the investigation of choice? I'm sure all of you know, so we'll skip this. It is ultrasonography, easily available at most centers, non-invasive, and helps you to diagnose tuberculosis. So do not misuse ultrasonography. Treatment of DSTB. The change has been that ethambutol has been added throughout the 6 months of treatment in the DSTB regime. And intermittent, the dots that was followed is now not followed any longer. It's a daily regime. The reason being that you have to hit the bacterium hard and hit it fast. So you need all the 4 drugs to be given at the same time every morning. Some mistakes were being made, that rifamycin before breakfast, INH after breakfast, ethambutol after lunch, and then pyrazinamide after dinner. That is not the way it is to be given. All the drugs are given together. So rifamycin before breakfast and all the other 3 drugs after breakfast at the same time every day, so that the therapeutic level is maintained and the drug can act upon the bacteria. There's no extension of the intensive phase. So if you have given 2 months and there's no improvement, you do not make it 3 or 4 months. 2 months is 2 months, you stop PZA and you continue the continuation phase. Sometimes we have extended the continuation phase from 4 to 6 months more. 4 months to another 3 months. That is total of 9 months. The second category which was existing, which was a retreatment, failure, or a defaulter, has been completely abolished. And even if there's a patient who has to be retreated, we first start DSTB only. That treatment regimen is started always. And the important is a refer resistance, where we assume that there can be a chance of INH resistance, therefore we manage it as MDR-TB. So all the criteria 2 have now become the first category DSTB only. So we had presumptive TB and now we have drug sensitive TB, the second criteria. For neuro TB and spinal TB, it is for 12 months, 9 to 12 months. Category 2 has been completely withdrawn. These are the drug doses. The weight-wise drug doses, you have fixed drug combinations available from the government, which are for INH, rifamycin, and pyrazinamide, and ethambutol is separately available, which is as a disposable drug. So this is my last question. What are the current recommendations on use of pyridoxine? A is 10 milligram per day for DSTB, TPT, 50 milligram for DRTB. B is 20 milligram for all patients on ATT, 25 milligrams for all patients on ATT, or 50 milligram for all patients on DSTB and DRTB. Can we have the voting session? Yes, so the right answer is that you have to give INH, you have to give pyridoxine to all patients receiving INH in any regime, and also for the drug-resistant TB. The dose is usually 10 milligram for DSTB and 50 to 100 for DRTB. How to monitor? Please follow up the child very closely. Once you have started ATT, you must call the child within the first and second week. Please see that they bring all their pills and medicines together so that you can counter check and count the pills, whether the patient is taking. A few patients we have found that the caretaker gives the medicine and the child throws it away out of the window. So please counter check and ask, does the child take the tablet in front of you? And then you can follow up every month. So your correct diagnosis, your correct combination, your correct doses, correct timing will definitely show you results. And then, of course, the response to therapy by clinical symptoms, radiological, and weight gain will always be there. Fever usually takes 3 to 4 weeks, so there is nothing to panic, because people think कि 3 हफ्ता हो गया दवा start करके and बुखार नहीं गया. But there is a study which has been done that only by 3 to 4 weeks, 94% of fevers respond. What to monitor? We already know you have a clinical symptom, you have radiographs if required. There is no need to do routine X-rays and sputums and LFTs for all children. Please do not do that. But if there are comorbid conditions, then we have to manage and treat them. But adherence to therapy is the key for the treatment and the success of the therapy. So pill count, social support. There are a lot of support given by the government. Please do find out from a NICSHE person. And if the child is still symptomatic, then we do a repeat X-ray or a sputum, otherwise not required. If there is no improvement within 4 weeks, or if there's a deterioration, then we immediately start investigating for MDR-TB by doing a pre-MDR-TB workup and starting the child on the this. This is a 9-year-old girl with knee pain and swelling since 2 months with arthritis. And these were her tests, HB 8.5, 4,600. Platelets were slightly low, TST and ESR were high. USG knee showed effusion, and MRI showed effusion, synovial thickening, multiple enlarged popliteal nodes with occasional necrosis. Looked like a tuberculosis. And someone outside started ATT in spite of these reports. And when after 3 months there was no improvement, the swelling pain persisted, he was referred to the state TB center to JJ. This is a case of Dr. Sushant Mane. He has shared it with me. So this was now thought to be a DR-TB case. But when he came to the center, when the child came to the center, the tests were repeated and they were found to be high again, ESR 110. So ESR going into 3 digits is highly suspect of a malignancy or a collagen. And now here this child has pancytopenia. Therefore, this was not a case of TB, but rather it was a monoarticular, pauciarticular JIA, and therefore the treatment was started. For that, ATT was stopped. So please remember that there are clinical clues against TB like persistent fever, pancytopenia, very high ESR. Look at the lymph nodes, not just a central necrosis, and there were no risk for DRTB to consider over here. This is my last case. It's an 8-year-old Muslim girl with pain in the left ankle, difficult walking since 6 months, and swelling since 1 month. This child's mother had died 6 years ago, and she had taken treatment for PTB. She showed in the orthopedic department in JJ, who advised rest for 2 months. And that time they had done a X-ray ankle showing left talus erosion, CRP negative, GL negative for gene expert. MRI showed erosion, and they did a biopsy which showed well-formed epithelioid granulomas, dense infiltrates, no evidence of caseous necrosis, and was referred to us to pediatric medicine. This was her X-ray, apparently looking normal. And this was her X-ray knee and an MRI, which shows definite erosions of the talus and calcaneum. So we investigated her again. Everything turned out to be negative. Sonography local angle was showing, of the local area showed muscles bulky, hyperechoic with loss of fibers, edema, etc. Ophthal examination was done again to rule collagen because she was a pivotal girl, 8-year-old. It was all normal, BCG scar was present. I sought a pediatric orthopedic reference outside JJ, and he did a excisional biopsy again by arthroscopy. Gene expert of that biopsy was also negative. MGIT was again negative, but ATT was started in April. That is HRZE with pyridoxine because of that first histopath report which suggested necrosis and no necrosis but epithelioid granulomas. And therefore she was on ATT. But what happened is from that site of arthroscopy, she started having a pus discharge and she was readmitted. Now we just send the pus again, but this time to Hinduja, and it grew Mycobacterium TB complex in 3 weeks. DST was done. It was found to be resistant to all first-line drugs, including fluoroquinolones. So now she became a case of pre-XDR, and we started her on the treatment based on her DST. So the full diagnosis was that she's a pre-XDR left ankle, GL and tissue NAT negative, but MGIT positive with RIFA and INH resistant, fluoroquinolone resistant, notification done. So when there is a non-responding child, we have to be very careful because we have to reassess our diagnosis, whether we were right in the first time by clinical history, contact, dose, duration, adherence to the treatment, whether it's a true non-response or a non-TB. So, and of course, there may be one underlying comorbidity which we have not addressed. Sometimes there is a paradoxical reaction or even a paradoxical upgrading reaction, PURs, which we should be aware of. So most commonly because of a poor regimen adherence, there may be a true patient who is not a DRTB, and of course there can be a true patient of DRTB either who becomes a presumptive DRTB again. So that is presumptive, and I don't know how much further should I go on. 2 minutes more I can take. So microbiological confirmation is required for all cases. Very few children with microbiologically negative disease or with extrapulmonary TB forms where sampling may not be feasible but have an exposure to MDR, we have to consider it as a presumptive DRTB. So poor response, no comorbidity. ATT for more than a month, loss for follow-up. Microbiologically confirmed TB. Child was cured after ATT and now has a relapse and now microbiologically confirmed MDR-TB, or a contact with an MDR-TB patient, or children living with HIV/AIDS, or children with a history of TB death in the family. Please consider these children as a case of presumptive DRTB. So that is why the universal DST strategy requires everyone to be tested upfront for resistance, and hence DRTB workup is not restricted only to the presumed DRTB, but to all patients who present to us the very first time with their symptoms. Some of the definitions that have changed, please read them whenever possible because you need to understand each one of them. So they seem jumbled up, but when you read it and you understand, you will see that each category is different. So monoresistant, MDR-TB resistant, polyresistant, pre-XDR, XDR. Please read up each and every of these if you can. And I really implore all of you all that whenever we are having an NTP module in Mumbai, please do attend in large numbers because it is for your training. It is people from practicing areas where we get the most, misprescriptive diagnosis and treatments. So that causes more harm to the patient than helps them. Then there is extensive or advanced TB, and there is severe extrapulmonary TB. So the severe form is also described when it is bilateral, when it is fibrocavitatory, when there are comorbidities. So we need to know all these. I shall skip this. I shall go to the take-home messages. Now, in the MDR, there are 3 categories, Group A, Group B, Group C. It is a very systematic, methodical prescription that is taken in written when we are giving a treatment regimen to an MDR TB or an pre-XDR or an XDR. It is not verbal. We actually write down the sensitivity of the child, and we see which drug from which category can be given, because there's a certain protocol to be followed. And if in any of these keys categories one drug is resistant, the sequence to replace is also a fixed one. So you cannot just replace this with this as you feel. There is a proper module for this, and we have to follow this. So you have a non-severe EPTB or a PTB, single pulmonary case, or you have a pre-XDR case where you have shorter oral DTR TB regimens and you have a longer. So these all need to be studied in detail and taught to each one of you all, because even age-wise, less than 5 years, less than 6 years, we cannot give bedaquiline and delamanide.
I think
So coming to the last slide of my take-home message, I'm skipping the TPT, that is TB preventive therapy. So children are not miniature adults, so childhood TB is different. We must stretch our limits as far as diagnosis and management of TB is concerned. Please try to get the bacteria by all means, even if it means an invasive method. DRTB is definitely a rising issue in children, and it is very alarming for that. Get a microbiological diagnosis in all patients before starting a treatment, even if it means an invasive procedure. Know when to wait and when to initiate the treatment. Standard therapy in all pediatric TB is 2 HRZE and 4 HRE. Non-response is non-resolution of symptoms at 4 to 6 weeks. Never add a single drug to a failing regime. CBNAT is almost 98% specific for the RF susceptibility or resistance. Phenotypic susceptibility testing is useful for knowing INH susceptibility. On treatment, new lesions can appear and previous ones worsen, so do not panic. This is usually a paradoxical reaction. It can occur at any site. So in CNS, new tuberculomas can come up, lung, lymph node, bones. Follow up the patient for adverse effects and adherence very diligently. The best strategy is to consult a DRTB center, and these are the websites that I have given over here. And the patient support is available from the government under the NTP by monetary support also. And lastly, I'm very happy to share and very proud to say that JJ is a state nodal excellence center for DRTB for children, and our nodal officer is Dr. Sushant Mane. So I'm very proud to say that we have achieved this milestone in JJ in the last 2 years. Thank you.
Thank you, madam, for that wonderful session and important updates in tuberculosis. We'll be breaking for lunch now. Just 1 minute of instructions before you all leave the room. Jain and Sankashti food is been kept outside, in the outside area where we had breakfast. We have a take-home message booklet which has been made for all the sessions. Please don't forget to take it towards the end of the scientific session. Faculty photos are been kept at the registration counter, so kindly collect those. And we have prize distribution for paper and posters at 5:15. So students are requested to please wait. And please come back in 30 minutes because we have a very interesting quiz coming up. I'm sure none of us want to miss that. Okay, so now we shall break for lunch. Thank you very much.